to everybody. I'm really, really happy, and thank you to all my friends that they came to be with us here and to share the knowledge. And I hope you enjoy the meeting, and I hope that you enjoy the city, because Bydgoszcz is my new town, and I like it very much, and I hope that you would like it very much too. So, without any longer introduction, I would like to ask also our director of our hospital, medical director, Agnieszka Rogalska, to say a few words, sorry in Polish, but she's really, really busy and she needs to rush and she needs to run to the next meeting, but she would like to welcome all together during this meeting. So please.
Dzień dobry Państwu. Jest mi ogromnie miło przywitać Państwa na dzisiejszym wydarzeniu. Ja jestem przedstawicielem zarządu szpitala. Jako partner tej konferencji jest mi niezmiernie miło, że takie wydarzenie w naszym mieście przy naszym udziale ma miejsce.
She just told you that she's the medical director and she's really, really happy that we are here. Okay, so
Chciałabym złożyć szczególne podziękowania pani profesor, panu doktorowi Wojtkowi Świstkowi za taki trud włożony w zorganizowanie tego przedsięwzięcia, bo tematyka chorych hematologicznych jest dla naszego szpitala strategiczna, jest niezmiernie ważna.
The topics of hematology for our hospital is really, really important, and she's really happy that we have so good speakers today with us.
Wszyscy widzimy, że pacjentów hematologicznych jest coraz więcej. Logistyka szpitalna, logistyka ambulatoryjna, przyjęcia, zaopiekowania się tymi pacjentami jest coraz trudniejsza, ale też są dobre informacje. Możemy się tutaj być optymistami, ostrożnymi optymistami, bo dzięki nowoczesnym technologiom, które wprowadzamy, rokowania tych pacjentów też są coraz lepsze.
Today we are going to speak about old drugs, but mainly about the new drugs, and she's saying that we are really having a nice, better future for our patients because we have much more new drugs to offer.
Życzę Państwu owocnych, interesujących obrad i miłego pobytu w naszym mieście. Bardzo dziękuję.
And of course, I would like to thank to the university, Collegium Medicum, because they are also helping us to organize this conference, but the dean of department is not able to be here because she's at the other conference. So she just wanted to tell all of you very warm welcome. Okay, so I think that we can start the first session. We've got some last moment changes in the session. The session is dedicated to the therapy of acute myeloblastic leukemia. We've got the first lecture of Agnieszka Wierzbowska. Agnieszka Wierzbowska is the AML lady in Poland. She's a really great consultant of acute myeloblastic leukemia in Poland. She's taking care of our Polish adult leukemia group, AML party in Poland. And I'm really pleased to introduce you and to give her opportunity to give the lecture about acute myeloblastic leukemia during our conference. Then my dearest professor, Maria Podolak-Dawidziak, will tell you a little about coagulation problems in acute myeloblastic leukemia. And at the end, we will have two lectures from Spain. There is a small change. Pau Montesinos will tell you about APL, about AML, PETEMA protocols, and I hope that you enjoy it. So without longer introduction, can we put the first lecture of Agnieszka Wierzbowska?
Good morning. First of all, I would like to thank organizers, particularly Marta and Wojtek, for inviting me to this excellent symposium. I am so sorry for not being able to attend in person. So I was asked to discuss the current treatment algorithm of acute myeloid leukemia. Let's start from the difficult part. So during the last decades, a tremendous progress has been made in our understanding of AML biology, thus revealing enormous genetic heterogeneity of the disease and also the clonal heterogeneity. There is evidence that AML evolves from the beginning of its development in each patient, and several studies showed that leukemic cells acquire subsequent mutations, and individual leukemias are composed of subclones with different mutational compositions. So the average patient with acute myeloid leukemia has usually at the time of diagnosis 4 to 5 different mutational clones, usually 1 or 2 dominant, and 4 to 5 the subclones. So this evidence clearly showed the high complexity of AML, which includes not only the interpatient genetic diversity, but also significant intrapatient genetic variety, which makes treatment of AML challenging. On the other hand, the understanding of AML biology has led to the identification of several intracellular signaling pathways that are critical to the growth of the leukemia and that could be a potential therapeutic targets. And of course, during the last decade, several drugs were approved for the treatment of acute myeloid leukemia. So the fundamental decision, the therapeutic approach of AML is to evaluate whether patient is eligible, so-called fit for intensive chemotherapy and should be cured or treated with the intention to cure leukemia, or if the patient is unfit for intensive chemo and should be offered with less intensive approaches to prolong survival. For more than 50 years, the combination of an anthracycline and cytarabine, often referred to as 3+7 regimen, has been a backbone of intensive induction chemotherapy in younger medically fit patients. However, this intensive chemotherapy approach has changed by the addition of novel targeted therapies to the chemotherapy backbone or the introduction of the new drug formulations in specific genetic subsets. And so let's start from gemtuzumab ozogamicin, which was the first approved drug in AML, the new drug in AML. The randomized study of the alpha group showed significant event-free survival benefit in newly diagnosed AML patients aged 50 to 70 years in the arm in which the gemtuzumab was added to conventional chemotherapy. And the German group also observed a trend towards improved event-free survival in nucleophosmin-1 mutated AML patients with the addition of gemtuzumab. The meta-analysis of the 5 randomized studies confirmed particular benefit from the addition of gemtuzumab in core binding factor leukemia patients. So in this group, the improvement in overall survival rate increased from about 55% to over 75%. And the moderate benefit was also observed in intermediate risk patients. The interesting study of the British group was recently published. In this study, patients not known to be adverse risk karyotype were randomized to daunorubicin, cytarabine, or FLAG-IDA induction with 1 or 2 doses of gemtuzumab ozogamicin. And this study clearly showed that for patients with core binding factor leukemia, the best outcomes were achieved with daunorubicin cytarabine induction with only one gemtuzumab dose with 3-year overall survival of 96%. An exploratory analysis from the same study also confirmed the significant benefit of FLAG-IDA-Go induction in a subpopulation of patients with nucleophosmin-1 mutation, regardless of the presence or not of the FLT3 ITD co-mutation. For FLT3 mutated patients, the benefit of FLT3 inhibitors in frontline setting has been demonstrated in 2 randomized trials. In ratified study, the addition of midostaurin to standard induction consolidation chemotherapy was evaluated in FLT3 mutated patients, including FLT3 ITD and TKD mutation. In a quantum first study, the second generation FLT3 inhibitor quizartinib was evaluated for also safety and efficacy in patients with only FLT3 ITD mutation, but in both studies, the benefit of the addition of FLT3 inhibitors to conventional chemotherapy was confirmed, both in terms of overall survival and also the reduction of relapse rate. And moreover, in this newer quantum first study, the treatment with quizartinib showed deeper responses and more often eliminated the measurable residual disease compared with placebo. Likewise, CPX351, which is liposomal formula of daunorubicin and cytarabine, also demonstrated improved complete remission rate and survival benefit in new patients older with newly diagnosed high-risk acute myeloid leukemia. And the study showed that for those patients who received allogeneic stem cell transplantation, those who had received CPX demonstrated significantly longer post-transplant overall survival. The intensity of the post-remission treatment should be individualized and based on the genetic risk group and patient performance status with comorbidity index evaluation, donor availability, as well as the patient's wishes. And whereas the favorable risk group patients clearly benefit from cytarabine-based intensive consolidation, the adverse risk patients should be always offered with allogeneic stem cell transplantation if they are in a good performance status and if only the matched donor is identified. So let's move to the novel approach, because in the era of novel targeted therapies, the concept of the maintenance has been revisited, and several novel maintenance therapies, including the epigenetic agents, targeted therapies, and also immunomodulation has been evaluated both in the post-consolidation and the post-transplant setting. And the Quasar study reported a significant survival benefit of oral azacitidine maintenance in newly diagnosed AML patients older than 55 years in first complete remission after intensive induction with or without consolidation. The role of the FLT3 inhibitors as post-consolidation maintenance is still unclear. They weren't a subject of the separate randomized clinical trials evaluating separately their role. However, they were investigated as the part of the investigational arm into randomized studies. So therefore, the only drug confirmed as post-transplant, post-consolidation maintenance, there is oral azacitidine formulation, but FLT3 inhibitors can be used as a part of previously approved protocols. Regarding, maybe it's worth mentioning that although commonly used, oral azacitidine maintenance was not evaluated for efficacy and safety post CPX treatment. But let's move to the post-transplant maintenance and the progress in this area. The only randomized study evaluating efficacy of regular formula of azacitidine as post-transplant maintenance was not associated with improved relapse-free and overall survival as compared with observational arm, but the meta-analysis of 14 studies evaluating also not only randomized studies, but also the retrospective analysis and prospective studies showed a favorable outcome of hypomethylating agents post-transplant maintenance in terms of non-relapse mortality, relapse-free survival, and overall survival. So therefore, although also not confirmed in a randomized setting, the post-transplant maintenance with hypomethylating agents is still commonly used in the clinical practice, particularly in high-risk patients. With regard to the FLT3 inhibitors, data on the post-transplant maintenance are more robust. Two randomized studies showed that post-transplant maintenance with sorafenib, although sometimes challenging to deliver, reduced the risk of relapse and improved overall survival without increase of the frequency of graft-versus-host disease. And in the second randomized study evaluating the role of second-generation FLT3 inhibitor gilteritinib, it was shown that gilteritinib post-transplant maintenance prolongs relapse-free survival only in patients with detectable MRD before or after transplantation, so in the peri-transplant period. And this study also included NGS PCR MRD evaluation prospectively and confirmed that these new tools could be useful to identify patients who may benefit from post-transplant treatment, and more or less similar observations were reported from the Quantum First study. Also, the post-survival benefit for patients receiving quizartinib in post-transplant maintenance if they were positive. So the available data suggests that improved maintenance strategies and also the combination of the superior tool to identify better and identify those patients who may benefit from a post-transplant maintenance may substantially improve the overall survival in patients with AML. So, what about the less intensive approaches? So in this area was also significant progress. And also in less intensively treated patients, the personalized approach is recommended. First, we should identify if patients harbor or not the IDH1 mutation and can be treated with personalized approach with selective IDH1 inhibitor, ivosidenib. The rest of the patients should be treated, so-called mutation agnostic patients, should be treated with ven-aza as a standard of care. And these recommendations are based on the results of Agile study, which clearly showed significant survival benefit of patients with IDH1 mutation treated with Ivo-Aza regimen as compared to placebo-Aza arm. For the rest of patients, very well-known results of the VIALE-A study confirmed the role of the ven-aza treatment as the standard of care for mutation agnostic patients and the benefit of this combination over azacitidine monotherapy. So this novel combinations and the novel drugs were implemented to AML treatment during the last decade, and the very recent analysis from MD Anderson Cancer Center shows the first signs of the further benefit of the long-term survival of patients treated after 2000 20 with novel targeted therapies. So we are really breaking the bad prognosis of AML. But just let me discuss very briefly some future directions. So for patients eligible for allogeneic stem cell transplantation, the personalized approach is developing, and several novel drugs, including FLT3 inhibitors, or IDH1, IDH2 inhibitors, or menin inhibitors, are evaluated in combination with intensive chemotherapy. Another strategy is to combine or add venetoclax to conventional treatment, and the preliminary studies showed a very satisfactory composite complete remission rate, up to 94% CRs, with the very high rate of CR MRD negative, with not significantly prolonged the early toxicity, and also we slightly prolonged the time to neutrophil recovery. So right now, two randomized studies are evaluating the role of venetoclax in the frontline setting. For less intensively treated patients, the addition of targeted therapies to hypomethylating agents venetoclax backbone is evaluated, and the preliminary phase 1 two studies show the very promising and very exciting results with the increased rate of the complete remission, but also, of course, these new approaches should be compared in the randomized setting. But of course, despite all this genomic and therapeutic progress, the treatment of acute myeloid leukemia is still a challenge, and it has been shown that the clonal evolution during the treatment leads to the emergence of the new clones, usually resistant to targeted therapies. So therefore, this clearly indicates that the genetic profile of AML may change during therapy, and that each subsequent line of treatment should be always tailored and adjusted to the current genetic profile of clones. So therefore, it seems that our treatment and current treatment of AML is the perpetual clone wars. So this is another fascinating story. So probably we might be, maybe we should change the movie for the future, from breaking the bad to the clone wars in AML. So I would like to thank you very much for your attention. So, and I hope I will be able to join for the discussion later. Thank you very much.
We can go to coagulation abnormalities. So, Marysia, please.
May I have a microphone, please? Well, I should say that it is not a secret that out of 10, or even 9 out of 10 medical students and doctors are not too fond of coagulation. It remains a secret for me why it's happening. The older am I think we can't teach them. It is a pessimistic version, and optimistic is that we may try, and I'm going to do this, to change the attitude a little bit. And definitely, both for conventional medicine and for surgeons, obstetrician, it's true that disturbances in coagulation can spoil each work. At the beginning, due to the complications. And let me just show you some my choices, because due to 20 minutes talk, don't be afraid, I'm not going to go through all coagulation problems. As we do remember, there is a first part of, sorry. I've spoiled it. The first part of coagulation, which start on the forming of platelet clot, and then those blood coagulation factors, they take part, and the queen of coagulation, thrombin, is being formed, and the last part, we should get rid of this fibrin, as we do not want to be stuck with a thrombi. Hemostasis works when it's a good cooperation between vessels, platelets, and clot factors. And we shall also keep in mind that coagulation goes not somewhere nowhere, but it goes on the surface of platelets, on endothelial cells, and sometimes in cancer patients also in neoplastic cells. And what I have chosen for a discussion with you, there are still ongoing studies in such a subject as disturbances in coagulation in acute myeloid leukemia. ISTH, different others, networks, they establish first facts going through different studies and document this. Even such a first easiest stage will found in a coagulation some disturbances as prolonged prothrombin time, APTT, lower platelets count. It is obvious when it's a neoplastic clone. And what may help? We do have in our hands a simple test, but quite costly. It's a thromboelastography. And this, if you see, and it is in real life the same, that it is a normal picture, and we will look when it says thrombocytopenia. It's much narrower and hypercoagulability like this. So those thrombotic complications, they appear, as you see, in acute myeloid leukemia in up to 12% of patients. But how about bleeding? Because we are, I think, not necessarily on a good way, are afraid more of bleeds than of thrombi, and we rather should do opposite. And it is quite low. Major bleeds, they are being observed in a big population patients, in about 43% of them, but life-threatening are with luck only in 1%. The situation which can be life-threatening if not being recognized quickly and treated properly, it's DIC. And you remember that it may happen in a different situation like descending aneurysm, giant hemangioma, some head injury in the brain and tumor necrosis, but also in leukemia. And it is the old name, I think, quite not bad. It was a coagulation of consumption, because it was a quick, unreasonable consumption for thrombi formation, platelets, coagulation factors. So it's not surprising that it will be platelet will go quickly down, fibrinogen as well, and we should remember that in some neoplastic disorders, fibrinogen is an acute phase reactant, And we shall look that it can be in the morning, let's say 300 milligrams, and in the afternoon 150. So it's a decrease, not necessarily, it's a tendency for decreasing, and the dimers will go up. What is worth to realize that when people from Italy with some cooperators studied DIC in AML in 161 consecutive patients, 52 did have a DIC, not necessarily in acute phase, but more often in chronic. And especially, and I'm going to move to this disease quickly, in acute promyelocytic leukemia. And it helps that there is accepted by ISTH as scoring for DIC, and more 4 points means overt DIC. And what is predisposed APL to this DIC? First of all, cells themselves, they express tissue factor, which is important in tissue factor dependent pathway, cancer procoagulant, release of cytokines, interleukin-1 beta and TNF, and they express promyelocytes. They express a large amount of annexin 2, which is a co-receptor for plasminogen and tissue activator of plasminogen, what means that it is augmentation of fibrinolysis. So it's actually a tendency for bleeding, and more promyelocytes, it's more active. And you can imagine if not having in use ATRA, we will try chemotherapy, so it will be a disaster. And when it is quite nice study published this year, looking at this over-disseminated coagulation. There is all leukemia group without APL, and it is APL. What I would like to stress your attention to, that it is more heterogeneous. There are less active and more active DIC, and APL, it is in a sense more compound. When you look at complication rate and this DIC score, it is so that obviously it's easy to predict that those with higher scoring will experience more complications, and for a score 6, which is very high, 10 out of 12, it means 83% had this. And it is interesting, what is a predisposition inside APL to DIC? So cells being coupled and an open APL. So if someone, and it is a APL society here, so I can direct you to this interesting paper. And they were using conventional methods, and the same D-dimers was higher, fibrinogen lower, DIC higher in those APL patients, but they're very, very small groups. So tendency can be actually mentioned, but it does require a bigger study. And the other complication, which is really dangerous, it's a result of endothelial cells damage, also inflammation and release of cytokines. I am thinking about transplant-associated microangiopathy, thrombotic microangiopathy. And you see that the tendency potential factor, there is a female, gender, gene variation, severe aplastic anemia. So we can try to find what are predisposer factors, which we are ready to do. We're trying to actually prepare ourselves and our patient. And if we look at those laboratory findings, they are, how to say, quite similar to those being present in thrombotic thrombocytopenia, which is schizocytes or schistocytes. There are changes in the shape of red cells due to presence of small thrombi. There is also immune anemia and other changes typical for hemolysis. And what are advices? I'm not going to go very deeply into it, but when it's a suspicion of TA-TMA, thank you, and later, and we shall perform a serious diagnostic evaluation and looking especially or present or not histiocytosis, proteinuria, hypertension, increase in LDH, and differentiate with TTP and DIC and other states being shown here. And eventually, if those criteria were not met, we just look on the different causes like GVHD or our treatment. If yes, we go further. If there is a lower than 10% Adams for 13, we consider plasma exchange and others as is indicated. And there is not, the different processes are being put on different shelves. So there is a communication between coagulation and complement pathways. And as you see here, it has been shown after stem cell transplantation, how does it go? So these rose ones, there is how coagulation influence complement pathways, and these gray ones, it's an opposite way. So we shall keep it in mind. And a good example is paroxysmal nocturnal hemoglobinuria, where 40% of patients still do have a thrombotic complication, and it is the strongest thrombophilia, acquired thrombophilia ever. And this pathophysiology of TMA, it's worth analyzing, because those drugs which are being used in a different combination, like immunosuppressant rituximab, and also you see here inhibitors of C5 or C3 complement pathway are valuable. And now I'm moving to new ways of therapy, which we shall observe very quickly, also trying to predict coagulation disturbances. This first belantamab, this bispecific antibody, has been checked, and it was found that some coagulation is being disturbed there. So we shall remember that. And also, this what we are proud of, CAR T cells, and in my department they produced and transfused those cells genetically changed to fight the neoplastic cells, they can be also complicated by some coagulation disorders. So there were here 100 patients, relapse or refractory, and there was both DIC and also cytokine release syndrome present. It's easy to predict when both they are present together, it's the worst combination. And also different institutions just publish sort of observation and clinical guidelines how to manage. So trying to summarize my talk, it isn't like in the real life, like I have shown in the beginning, that it slowly goes, platelet activation and platelet clot formation, hemostatic cascade and fibrinolysis. It goes quickly, jointly, and there is initiation, amplification, propagation, and stabilization. And even worse, I should say, and good, that this lab scheme that we are all familiar with, that it shows extrinsic, intrinsic pathway. It's a simplification of simplification, but I hope it will encourage you to study deeper, and you wouldn't tell Marta that it was most boring and awful talk ever. Thank you very much.
Okay. So now we are specialized in coagulation, so we can follow with coagulation problem in APL, but not only this type of problem. Paul, please.
Hello, everybody. I would like to thank Marta and the organization for inviting me to Big Dodge. I don't know how to. Okay, I don't know how to write it as well. I will address, as you will see in part of the next talk, coagulation problems in APL, and the title of this the movie here could be Miracle in APL Street, but I prefer to say APL Nightmare in AML Street. The reason is that even I think that in our mind we consider now APL like non-AML. It's like, but it's an AML, okay? It was the worst AML on the beginning due to life-threatening complications and early mortality. It was the worst. And we can say that there is a miracle because now it's the best, but it still is an AML in the middle of the nightmare of the rest of AMLs, I would say, with the exception probably of core binding factor and some NPM1 mutated patients, which are the long-term followed patients in external consultation without transplant, because patients that are transplanted, they have a new disease, that is the transplant. So I will address in the next 15 minutes, I hope, the real-world outcomes. So I want to stress also another reason to say that still we could have a nightmare with APL. Nothing is marvelous. There is no good AML, no good leukemia. So when an APL patient is coming to emergency room or the first consultation with diagnosis, and we could have the desire to tell to the patient that don't worry, you are lucky, you have a good leukemia. No, there is no good leukemia. So we will address this, and we will focus on early death and, of course, bleeding and thrombosis. And then I will address the frontline treatment, and I will keep on high-risk strategies, okay? Because I think that for low, intermediate risk, there is no more to dig in. once the patient is not dying during induction. Just maybe in the future the oral formulations, but I will not address this in detail. So what is high risk? The first, the classical concept of high risk APL is patients with more than 10 white blood cell counts at diagnosis, so at presentation, not 3 days after receiving ATRA or differentiating agents. This is very important. And this was established by a joint study by the PETEMA and the GIMEMA groups, where they observed that patients with more than 10 white blood cell counts at diagnosis, they had worst overall survival and relapse-free survival. Now we also made the distinction between intermediate and low risk based on platelet counts. Now we tend more to speak about high risk, more than 10, and standard risk, less than 10 white blood cell counts. And this is in the context of ATRA plus idarubicin-based regimens. We can challenge that if this definition of high risk based on 10 white blood cell counts is applicable yet to arsenic trioxide plus ATRA schedules. And it is important to go beyond the high-risk APL. I don't think now is based on the 10 white blood cell counts, but we have many other more powerful reasons to classify a patient as with APL as high risk. And you can see, of course, here in the slide, this is a US study, how the high-risk patients with high white blood cell counts, they have early mortality, 27%. This is a population-based study in the US. Not population, it's a hospital-based study in the US. Sorry. And real life, okay, all patients, all comers. And we have lower rates of early death with less than 10 white blood cell counts, but still you can observe high induction death rates, or induction or before starting therapy even. And then the authors of this study, they argue that maybe there could be some correlation between following guidelines or not following guidelines in therapy and diagnosis and the rate of early death. So I will focus in and it's not a very recent analysis, it's 1 year ago, analyzing patients in the PETEMA and the PALC database. We have 4,000 available patients at that time, and we can see how 1/3 of patients will not be available for protocol, okay, will not be eligible for protocol. So those patients, will not be usually published as outcomes of a protocol because they are excluded from a protocol. And there are many patients that they do not fulfill criteria. This is not a clinical trial, but it is a protocol with some inclusion-exclusion criteria like ECOG performance status, secondary APL, severe comorbidities or lack of genetic diagnosis. This is important because this third of patients, they tend to not appear in the outcomes that are published of protocols in cooperative groups, and of course clinical trial situation should be even worse than this. So real outcomes are not those published in clinical trials or in protocols from cooperative groups. And it is important because you can see here how the characteristics of patients with exclusion criteria are different than those that are eligible for protocol, in particular ECOG performance status, white blood cell counts. There is more hyperleukocytosis in patients unfit, or because they could be unfit just because of the disease, but it's difficult to distinguish. Early death, they never get treatment, ATRA even, so they are not eligible, of course. And these are the long terms, the true the crude reality of APL. It is true that this is a historical registry. We have patients more than 30 years ago, okay, and you will see the evolution of the therapeutic outcomes. But by the end, at the 10 years, we have a 30% of patients with APL that have died, and the majority of them due to leukemia. And this is a high risk, ECOG 3-4. What is ECOG? I think that ECOG is our eyes on the patient. Okay, so we are a very strong. I won't speak about artificial intelligence, but I prefer to speak about natural stupidity. But we are a very strong tool to predict the outcome of patients based on our sensitivity. And of course, you can see here the high-risk patients based on white blood cell counts, very bad outcomes, especially drop of the curve, survival curve in the first month, up to 25%, very similar to the study of the US. This is real life. And we can see how survival improved over the last decades. The black curve is just the first protocols that we were introducing ATRA in the early 90s. We were collaborating a lot with the French group, Pierre Fenot and Miguel Sanz. They were together in this venture. And how then we had some IDA risk-adapted protocols with slight improvements over the different protocols. And finally, our last protocol, LPA 2017, is with arsenic trioxide introduction just for the low intermediate risk patients. And there is, again, another step beyond. But here you can see the prognosis of patients excluded in the right curve. Patients excluded for protocol, lack of genetic diagnosis, unfit, secondary APL, patients that were not following the protocol for any reason. All those patients, they perform especially bad. So for patients that are usually published in APL, we have 10 years overall survival of 75%, which is remarkable if we compare with other AML forms, and especially if we go, this is more real life, okay? Even if they are eligible for protocol is not clinical trial, true clinical trial. But still there is a lot to improve. This is the reality. When you see early death rates of 0%, as was presented before, FLAG-IDA plus venetoclax, okay? There's something wrong there, okay? This is not the true. And here is the same. We should have our feet on the ground. So we analyzed early death among 3,800 patients in the PETEMAPAL registry, and we observed 15% of early mortality. This means induction death, so dying during induction period or dying before starting therapy. This later category was around 3-4% of patients that they die before receiving even one pill of ATRA. And these were the causes of death. Hemorrhage is the predominant, followed by infections. Differentiation syndrome is also very important. And thromboischemic events. This is not, we cannot disregard this cause of death. And you can see how patients eligible for protocols, those that will be published, the early death rate is still up to 10%, not 0%, but 10%. But when we go to patients excluded for protocol, early death rate raises a lot. And also we can see that the causes of early death are different between the category of patients. Secondary APL, there is an even between infection and hemorrhage. And this is more due to the characteristics of those patients that are older patients. They tend to be more cytopenic. Also more comorbidities, of course. So they are more vulnerable to infectious complications. But still, hemorrhage is the main cause of death in this population as well. And this is how the mortality rate evolved during our protocols. I'm sorry because there is one category that is missed up, but this is 100%. And we see, of course, a dramatic improvement with the AIDA-based protocols. And we were, in the overall population, like 15% of early death rate. And the trend to improvements in the later period, from 2012. This protocol is just with arsenic trioxide included in low intermediate risk. But there is not a clear improvement in the last 20 years regarding early death in the real world. So here maybe we could see a trend to less infectious death, maybe, because we are using less chemotherapy, but this is something that we have to analyze in a better way. It's only hypothesis. And what about the sites of lethal bleeding? The problem is CNS hemorrhage, CNS bleeding. Okay, this is the also pulmonary is important cause of lethal bleeding, and gastrointestinal less. We observed and we published that gastrointestinal bleeding was most common in the later weeks of induction, and probably due to we were giving high darubicin to the vast majority of patients, so maybe something related to mucosal barrier disruption and so on. And also, the bleeding, CNS bleeding, is occurring in the first week mainly, and then in the next weeks of induction there is more similar distribution about different causes of death. Okay, so with more predominance of infection in the later phases of induction. And CNS hemorrhage, particularly in the first week, is the... So, what can we do to improve this? One strategy could be to predict these complications. This is an attempt of a Swedish group in a joint study with Portuguese colleagues, just to build a score and to validate the score system, but to predict early death. But I don't think that we want to predict early death. We want to predict the cause of early death. The prophylactic and the monitoring measures are not the same to prevent death by infection than death by differentiation syndrome or death by thrombosis or hemorrhage. So what we did, and this is not published because of a lack of time, we did a second study because the first was published in 2010, I guess. We enlarged the series with these 4,000 patients, and we did a multivariable analysis just to see the factors related to early death: age, white blood cell counts, ECOG, LDH, creatinine, blast in peripheral blood, secondary APL. But we can make a multivariable analysis and the score system just to predict hemorrhagic death. Are not the same factors necessarily: age, white blood cell counts, ECOG, creatinine, and blast in peripheral blood. But we don't have to forget thrombosis. We have a consumption coagulopathy, hypercoagulable and hyperfibrinolysis. They can be together, but probably the phenotype of patients having thrombosis and hemorrhage is not the same. And regarding thrombosis, when we go to retrospective studies, the rate of thrombosis reported in APL is low. As you see here, 6%, 5%, 4%, but when we look prospectively, and this is what we were doing in our CRFs in the last 10 years, we were asking to the sites to prospectively collect the rate of thrombosis during diagnosis and during induction, then the rate is much higher. We can have around 5% at diagnosis plus an additional 9% of thrombosis during induction. And then we have performed an analysis. This has been submitted to publication. And we have seen on 1,200 patients that the rate of thrombosis during induction, thromboischemic events, is up to 14%, diagnosis and induction. Consolidation phase, less problems. And we performed a score, a multivariate analysis, and the score to predict life-threatening thrombosis. So we excluded patients with thrombosis related to surface vein catheter or central venous line because we consider that this is the main factor for thrombosis in that patients. So we excluded this. And we analyzed the factors to develop thrombosis in the rest of patients, which is the majority of patients in APL. And we found several factors that I will describe. And what is very important is that the early death rate of patients with a thromboischemic event during induction or at diagnosis was up to 31%. So this is a life-threatening complication. Most of them, they die due to the thrombosis itself or thromboischemic event itself, and there is a percentage of hemorrhagic transformation leading to death. And we developed a score. The name is Thrombone score. And this was validated. We developed the score in an AIDA cohort of 1,200 patients. And we validate the score. And this is the validation and the ROC curve of the validation cohort in around 500 patients treated with arsenic trioxide and DATRA in the later 2017 protocol. And the score looks to work well. And what we find is that patients with higher platelet counts at diagnosis, older patients, worse TECOG, prolonged APT time, that I do not know how to interpret that, okay, but this was an independent factor. And there was another risk factor that I do not remind now, sorry. Those patients had a higher risk of thrombosis. So we can modify at least our how we manage the patient, how we try to give more or less platelets to correct more or less the coagulation factor, even to give or not to give some prophylaxis with heparin, for example. We can adapt in the future our management based on this score. And we will include in further protocols. So what is the conclusion of this part of the talk is, this is the ELN 2019 guidelines, the last update in APL, and there is a clear consensus of the panel that the patients with APL should be managed by an expert team and having access to rapid diagnosis, rapid instauration of differentiating agents, and of course, all the supportive measures that are necessary for those patients. There was, I think, the uncertainty on how to treat patients with high-risk APL, because in the low intermediate risk, this was, let's say, clear. After the GIMEMA trial, phase 3, by Francesco Lococo and colleagues. So how we address high-risk patients? The chemotherapy-based approach, this is the PETEMA experience, showing a decrease in the relapse rate by intensifying chemotherapy with anthracycline and cytarabine in consolidation in high-risk patients. It did improve, but there's still many patients relapsing. So there are other ways that have been developed in the last decade, especially. There is the chemotherapy-free approach, but I will speak a little bit on the third way, that is combination of chemotherapy, ATRA, and arsenic. This is the Australasian study. It was quite intensive on the beginning with idarubicin, ATRA, and chemotherapy, and they added arsenic trioxide. This was a comparison of two protocols, and the later protocol with arsenic trioxide in induction and consolidation, they offer very good results. This is the Shanghai group that they combine arsenic trioxide. Sorry, it's not good here. Arsenic trioxide plus ATRA and chemotherapy only during induction, and they have a good results, but still the high risk have not the best. This is again another study combining arsenic trioxide, ATRA, and chemotherapy in high risk. But you can observe that arsenic trioxide is here only in monotherapy, not in combination with ATRA. and consolidation is not containing arsenic trioxide. And results are quite standard, like AIDA-based protocols. This is a pediatric study where this is Chinese, where they give ATRA plus arsenic trioxide and real formula. This real indigo formula is like oral arsenic, and they have a very good outcomes. But this is pediatric, and they still use chemotherapy. And finally, the two studies that have confirmed the use of arsenic trioxide in APL. This is the NCRI, the UK, and they compared AIDA with arsenic trioxide with a dense schedule. Okay, this schedule is coming from MDS treatment. They gave Mylotarg, one single dose, with patients with high risk, more than 10 white blood cell counts. And this study was not conclusive, unfortunately, because this group did not find differences in high risk of AIDA versus arsenic trioxide plus ATRA. And they did not find these differences because probably because there was more relapses in the chemotherapy arm, but many of those patients, they were salvaged using arsenic trioxide in second line. Okay, so this could be one reason. This is why it is very important to have a good clinical trial design, and they could not make a double-blinded study that probably the results were different. I will skip this and I will go directly to the Apollo trial. This is a pan-European initiative. We gave as a control arm the LPA 2005 protocol with intensification with Ara-C in high risk and maintenance. And we compare with the Lococo regimen, the so-called Lococo regimen, but we gave 2 shots of idarubicin on day 1 and 2 in high-risk patients. Okay, this is only for high risk. And the reason to give these 2 shots of idarubicin was mainly to permit a minimum time for randomizing the patient, to make all the procedures necessary to randomize the patient, and then to get access to arsenic trioxide in the context of the clinical trial. Of course, there is also to cytoreduce the patient. And the trial had similar baseline characteristics between arms. Here, the problem is that we were not able to enroll the 250 patients. It was 133 patients only. And we had to stop the trial without enrollment goal just because of lack of medication of clinical trial. It was difficult to enroll, really, and lack of economical support. But we were able to make analysis and to find substantial differences in toxicity during consolidation phase, especially thrombocytopenia and neutropenia were more pronounced as expected in the chemotherapy plus ATRA arm. Other toxicities like hepatotoxicity, QTCF prolongation, differentiation syndrome were not reported by investigator as substantially different between arms. We had a similar death rate between both arms, 7 and 10%, which is low. It is not real life, okay, for high-risk patients. And what is interesting of this trial is that in spite of not being able to enroll all patients, there was a primary endpoint was met with event-free survival, significant difference between both arms. However, overall survival was not significant between both arms. Also, important that this Apollo trial is not including older patients. So there was a capping of age to 65 years old because it was a quite intensive consolidation schedule with chemotherapy and ATRA in the control arm. So we didn't want to include older patients. So we have some experience in older patients treated with arsenic trioxide and ATRA versus AIDA-based. And this is a pan-European study, registry study between France, Germany, and Spain. And we found that patients treated with chemotherapy-based, They were more frequently high risk than patients treated with ATO and ATRA. This is a significant difference. Early death rate was also higher in chemotherapy ATRA than ATO plus ATRA, but this is probably due to differences in population characteristics. And when we go to outcomes in relapse-free, we observe that patients with more than 10 white blood cell counts treated with chemotherapy and ATRA regimens, they had worse, significantly worse relapse-free than those with less than 10 white blood cell counts. In chemotherapy ATRA, there was a difference between more than 10 less than 10, but when we go to ATO plus ATRA patients, there is no difference between high risk and low risk regarding outcomes. So this is a good signal regarding that ATO plus ATRA regimen could be also a good option for older than 70 years old patients, even if they were not included in the Apollo trial. And you can see also here the differences in relapse between ATO, ATRA, and chemotherapy ATRA arms. So this is the current PALG and PETEMA risk-adapted strategy in APL. Low intermediate risk, chemotherapy-free, let's see, but arsenic trioxide and ATRA are chemotherapy by the end. And high risk, we still keep with AIDA, but I think that this is something that has to change, and we have to see how we can get access, homogeneous access for our patients to arsenic trioxide and ATRA, because I think that we cannot build a protocol with some medication that the patients they cannot receive, because the objective of the protocols is to offer homogeneous approach to our patients. And that's it. Thanks a lot. Oral arsenic, I think it will arrive, but it's taking more than needed. In China, they are using a lot, but here we have different regulation and requirements. Okay.
As I told you, we've got some small changes in the program. We skipped the last lecture, and thanks to Pau, we've got the possibility to listen about PETEMA AML protocols. So please.
Okay. No. Thank you for the last minute offer to speak about the PETEMA protocols. Okay, it was yesterday, so I say okay because I cannot say no. And I will speak about the PETEMA AML group experience. I had to invent a title for this meeting, so I choose Peterminator, but I think that this is because we are finishing with our investigators. Okay, they have to work a lot, and they cannot stand more. We have a lot of activity, and this is for free. Okay, this is based on their willing to collaborate. There is no economical compensation in the PETEMA group for investigators, so it's just because they love it, I think, to collaborate. So this is our approach to AML, to fit patients. Okay, the unfit patients, they are in another slide. But for fit patients, what is important is that, first, this is the preferred option, clinical trial. Okay, so I don't see any reason to not offer clinical trial as a first option, whatever clinical trial, to our patients in AML, even CBF. No, it's some investigators, they can think that it is not ethical to offer a clinical trial because we have standard of care. But I really don't think that we still have a standard of care in AML, even in favorable risk AML. Everything should improve still a lot. So if there is a clinical trial, of course, that passed all the regulatory, all the ethics committee, who I am to say that this is not a good option for the patient. Anyway, we have very important, the second important point here is a central screening platform. We know with the aim to include patients in clinical trials, the primary aim, especially targeted therapies, precision medicine. So we need this central screening platform at a national level. Of course, if the patient has no clinical trial, we will use the central screening results just to offer the patient one or other protocol, and we dissect our assistential protocols as we dissect the disease genomically. And we have one protocol for CBF, one for NPM1, and one for the rest of leukemias. Maybe in the future, I don't know, we will have some protocol for MLL, for example. And the flow protocol, all these protocols, they have in common that is MRD guided, okay, for the post-remission algorithm. And here is by flow, and this other two is by quantitative PCR in peripheral blood. So the most important, the central screening platform. This is critical for us because it's not only permitting our patients to benefit from clinical trials and for MRD-guided protocols, also to correctly stratify patients in terms of prognosis and indication of transplant after complete remission, but it also has boosted a lot our registry. The registry is the basis of our cooperative group. Now there are possibilities to do clinical trials with new drugs, but maybe in 10 years we will not have. And 10 years ago, we had nothing. So the heart of the cooperative group should be what will be always present. This is the registry. So once patients are, there is a suspicion of AML, the patient is registered online with a very minimal information just to produce a unique patient number, and this unique patient number will be used for communication between the office, the central office of data, between central laboratories and the clinician. So this UPN is generated in the web, and then the sample is shipped with this UPN. Everything, of course, should be confidential. And the lab, once he has the result of the sample, NGS, PCR, flow cytometry, the lab will upload the report in the web, and this report will be sent automatically by email to the investigators. Okay, so the communication is, so this is why I say that the central diagnosis platform has boosted the registry a lot. Before we were registering like 600 patients per year. Many of them, they were retrospective, others were prospective. Now we are registering 1,600 patients per year, and the vast majority of them, they are prospective because this UPN that is generated. And here are the central labs of the PETEMA group. There are 2 in Portugal, 7 in Spain, and we are in process of validating 1 central lab in Colombia, 1 or 2, and also expectations to have 1 central lab in Chile. That this means that they are working with similar harmonized procedures, not standardized. This is impossible. And they are using this platform for information. We have now we have more than 30,000 samples that have been digested by these central laboratories. The vast majority are NGS or PCR, a diagnosis, but also follow-up. And we are able to measure, to have a good follow-up on what is going on in the central labs. For example, on the timing of diagnosis. We know that the median time to report cytometry is 3 days. The median time to report PCR is 8 days. I include relapse and follow-up, minimal residual disease, and diagnosis. We have a median time of diagnosis of 5 days. So we are able to make all the quality, let's say, parameters and to interact with the labs in order to improve. Because the people, they will not send the sample if they don't receive something in exchange. That is a report that is useful for the patient. NGS is 25 days. Now we are implementing rapid NGS platforms in 2 of the 9 central labs. We are able, in these 2 labs, to generate a report between 48 to 7 days, with a median 5 days now in the last year. And this is critical for what is coming, especially when we want to diagnose a patient of MLL rearrangement. We are doing by NGS. We are not doing by other technique. And it is more rapid than FISH or karyotype nowadays. This is the APL registry. I miss the rest of the world, but APL and AML registry. In Europe, we have several countries like Poland, but also France or Czech Republic, that they are participating in the APL registry only, not AML. In Poland, we have a joint venture, not only in APL, but also on rare diseases, BPDCN and mixed phenotype leukemia. And this is countries in Hispano-America. Now Peru will join also the platform. They are using the common database. In some of those countries, they built an acute leukemia group de novo, and they are willing and they are very happy, and we are also very happy that they participate in the registry, and it is a mean for those countries, those investigators, to generate knowledge. They have, in many of them, they even don't know what are the characteristics and the outcomes of their patients. So now they are starting to build these registries, and they think that this is a very fruitful and long-term collaboration between all of us. And we have so far now, we have 32,000 patients registered. This is not updated. Man, it's stuck here. Okay. Why do we want a registry with so many patients? We don't know, but we can do things with this data. Okay. For example, this is recently published. We asked the question: is autologous stem cell transplant useful for AML as intensification strategy? So we did a comparison between patients with induction, CR1, 2 cycles of consolidation, and then more consolidation or autologous. And we have a cohort of 1,300 patients, and we compare them, the outcomes, the characteristics, and we have results that were, I know that the investigator that led this study was Ana Alfonso from Navarra, Clínica Universidad de Navarra. She wanted just to demonstrate that autologous transplant is not useful, okay? And she told me, I said, okay, go ahead, demonstrate it, okay? And unfortunately, she found, and the most important in the multivariate analysis, that autologous stem cell transplant in the propensity score match cohort was an independent risk factor for relapse-free survival. So it's nothing new for us, really, because we are recommending autologous stem cell transplant for a long time, but this is reinforcing us to keep this strategy in our patients. So the registry is a source of knowledge, but we have to go to make the question, to pose the question, and really to know the truth, or the truth now. That could change, of course. This is the multivariate analysis that I told you. This is not based on the registry, but for example, for us, when we want to select sites for a clinical trial, we go to the registry, and we are looking on the metrics of each institution. We know how many patients they diagnose. We know how the investigator is committed to each project. So it is useful also to connect with sites and investigators. And this is the other aim of the PETEMA group, that is to make high-quality clinical research, not only based on registry, which is very interesting, but we need to perform clinical trials, and especially well-designed trials, as this Kiwi phase 2 trial. This was a randomized, double-blinded study, 270 patients, 3+7 plus quizartinib versus 3+7 plus placebo, 2-to-1 randomization in FLT3 ITD negative patients. And this study is already accepted for publication, and hopefully you will be able to read everything on the supplementary material, everything. But we found in this population that quizartinib improved event-free survival and improved survival, overall survival significantly in FLT3 ITD negative patients, which is a nonsense theoretically, but this is what we have. And in the forest plot analysis univariate, you can see that almost all groups of patients, they benefit from the addition of quizartinib. So the benefit was almost in all, but especially some populations like NPM1 mutated patients, FLT3 TKD mutated patients, DNMT3A mutated patients as well, while P53 mutated patients, they did not show a benefit on the addition of quizartinib to 3+7. There is also another trial using quizartinib in FLT3 ITD negative patients, but here also FLT3 ITD is a phase 1/2 to establish the recommended phase 2 and 3 dose. I would say recommended phase 3 dose. And it was a triplet. We started in 2020 to enroll those patients in triplet, unfit patients, but here is not the triplet of MD Anderson, okay? It's a triplet in really unfit patients, okay? The median age here is 76 years old. Azacitidine or low-dose Ara-C plus quizartinib plus venetoclax. And this was extremely toxic. We had a lot of issues. We had to do 4 or 5 amendments. We are not a pharma company that we do an amendment for everything. We have to be very careful with each amendment, and we were forced to do 4 amendments just to reduce the dose, to perform early venetoclax, early bone marrow assessment. It was difficult to manage. However, when we look at patients with de novo AML, which was half of the cohort, without an exposure to azacitidine, those patients, still we have at 3 years almost 45% of survival. The median overall survival in this population was 27 months. And when we look at NPM1, for example, it was 29 months, FLT3 ITD mutated, they do not reach the median overall survival. So this was a reason to design a phase 3 trial. This trial has not yet started, but is 376 patients, and we will compare this triplet, venetoclax, azacitidine, and quizartinib, but we have reduced venetoclax to 7 days because we do not want to have patients 50 or 60 days in cytopenia, okay? And this will be compared with the standard of care, venetoclax, azacitidine, but we exclude secondary AML to myelodysplastic and myeloproliferative syndrome because those patients, they do not benefit, I would say, they just benefit from treatment, whatever treatment you want to give them. This is better than not treating them, but there is no better treatment than other. We have also another trial that will start on the beginning on 2026 as well, is this oral decitabine plus ivosidenib, and we want in this study to offer a full oral schedule to patients with IDH1 mutated AML, and we include a cohort of patients that could be fit between 60 and 70 years old, and they could receive induction with this schedule, and then transplant, and then maintenance with ivosidenib. But the majority of patients will be unfit patients. It's just a new schedule. This is a very important trial that we will also start in 2026. It's a collaborative study with the French groups. We will compare 7 days of venetoclax with 28 days of venetoclax. Unfortunately, this is not open label. This is not double-blinded because we had no money to buy all the venetoclax and to label all the venetoclax for the control arm. So it's impossible. And this is supported by an association of patients, this study. It's totally independent and academic, and we will see after 6 cycles to see the rate of complete remission, event-free survival. We will see the deepness of response with centralized assessment by multiparametric flow cytometry. And this is our current standard in CBF. we give Mylotarg, but we give not only during induction, but also 3 cycles. We will probably change it, and we will just give 1 dose of Mylotarg in the future to avoid unnecessary toxicity. And we will probably cancel these doses of Mylotarg and include autologous stem cell transplant here. Because we canceled the autologous transplant in this population once we started with Mylotarg, because we cannot give Mylotarg and then perform a transplant which is based on the busulfan and the topoisomerase and high-dose cytarabine. This is the MPN1, still working. We will amend and to include here also quizartinib. There is no reason to give midostaurin or quizartinib. We can give both. This we will leave at investigator choice. But this is guided on MRD in peripheral blood, and patients testing negative in peripheral blood for MPN1, irrespectively of FLT3 status or other factors. Those patients, they go to autologous transplant whenever it is feasible, or more high-dose Ara-C. PCR positive after consolidation, then allotransplant. Based on this strategy, this is the analysis of the protocol 2017 for FLT3 ITD mutated MPN1. The blue is the current protocol, and red are previous protocols, not MRD guided and without FLT3 inhibitor in the FLT3 mutated patients. So we are in the right direction, and also we find that these are MRD negative post-consolidation and FLT3 negative patients. They are the best one. MRD positive and FLT3 negative, and MRD negative and FLT3 positive, they are in the middle, and the worst patients are MRD positive and FLT3 positive. And also we look at the post-remission strategy, and we see that autologous transplant is the blue curve, performs very well, also in patients with FLT3 ITD positive, but if they are MRD negative. Okay, so this is consolidating our strategy in the protocol. This is the flow that will be amended very soon, and this is for older unfit patients. Very important, IDH1, the preferred option is AZA, cytidine, evosidenib. P53, we recommend oral decitabine or azacitidine monotherapy. And these are our real-life results, 11 months in HMA-VEN and 8.6 months in HMA. These are almost 2,000 patients in these 2 curves. And we see that secondary AML, unfortunately, we have not improved when we go to compare HMA versus HMA-VEN. And when we take de novo AML, HMA-VEN is giving 14 months, which is similar to VIALE-A, while azacitidine is 10 months only. We have a guideline for relapse. I will not go on, and now we have 250 patients with BPDCN that will be published very soon, and this is the MPAL protocol that I think probably Marta will speak to you. And thanks for your attention, and sorry to be more than 5 minutes ahead of a schedule.
Now we've got time for questions. If anybody would like to make any questions to the speakers, so please go ahead.
Two questions to Pau first regarding the APL. Do you have any suggestions about like this intrinsic, poor responses to ATRA treatment? Do you think that might be related with different, RARA mutations, or any other ideas why basically we are seeing like still very heterogeneous responses in the APL patients? That's the first question. And the second question is, like, we know now from the reports of Garcia Manero that azaven was kind of like not really improving survival, right, in patients in AML. So my question is, do you confirm like very similar observations as Garcia Manero was, recently reporting in AML? And do you have like any idea how we could basically improve, those survivals in AML?
The report of Garcia Manero, what is this report?
So there was no further improvement in venetoclax plus azacitidine treatments in AML patients. This is kind of like the newest results from the clinical trials.
But in what population?
The novo AMLs.
In unfit patients? Okay, I am not aware about this, but what is clear is that the real-world studies, meta-analysis or systematic review, unfortunately are not showing great improvement, okay? We did a systematic review, was published almost 1 year ago with more than 7,000 patients in 70 different studies. And we observed, first, one phenomenon is that when you go to publish the studies, the median overall survival reported and the outcomes are better than non-published studies, okay? But we wanted to go to all sources to abstract everything. So, of course, there is a bias with better outcomes reported in the literature than the reality. This is something to be accountable on. But I don't think that we can say that venetoclax did not improve our patients and fit patients. In real life, in the clinical trial, of course, yes. In real life, there is a substantial improvement, especially in patients with de novo AML, okay? And I think the way to improve is to select better the patient's candidate for HMA-VEN, okay? So I don't think that we have to give to everybody. We have to be less subjective and less sensitive and based more on data and outcomes. You say, no, why I won't give venetoclax to this patient? This is the best therapy. But if you go to data, this is not supporting your feeling, okay? Or what you have been told by everybody. So we have to rely on our data, especially, more than data on the literature, but the data that are generated by our own institution or collaborative groups, and then to select better patients. For example, the P53, we prefer to give a less toxic approach, oral decitabine or azacitidine, than giving a combination for patients that will not be transplanted. So I really don't care a lot about remission, and remissions that are observed in this population often are not true remissions. It's just, you can have this kind of remissions with hydroxyurea also, okay? IDH1 mutated patients, we clearly prefer to go with ivosidenib because of the trial results and especially because of tolerability. And another way, a part of selecting population is, in my opinion, but this is, I have no consensus in the PETEMA group regarding this, is by significantly dose reducing venetoclax. In our institution, we are giving only 7 days of venetoclax. We have 70% of complete responses, and we don't have patients always on hospital, okay? So we feel much more comfortable with this schedule. However, when I go to the cooperative group, there is no consensus to give this 7 days schedule, which I think is very prudent as well, not to give to everybody in a protocol this 7 days schedule. So we say 14 to 21 days, but not 28 because nobody is doing 28, okay? We have a trial, a clinical trial, randomized trial, 7ATHA with the French group, where we will compare 7 versus 28. But the way, in my opinion, to improve the outcomes for our unfit AML patients is targeted therapy. So we have to follow this path.
And I agree with you, like in this point that we should actually be able to offer the novel AML patients clinical trials, and basically address like those genetic alterations like upfront instead of waiting until patients are really relapse refractory, because I think there's so much change in the biology of the
No, this is clear. Menin inhibitors, they will change nothing in the relapsed refractory setting. They will change nothing. And it is I have heard colleagues from US saying that menin inhibitor, revumenib, is the new standard of care in NPM1, KMT2A relapsed refractory AML. For me, this is absurd because it is 6 months overall survival. This is the new standard of care you want? So, of course, as you say, for relapsed refractory, one single agent will not cure the patient. You can bridge to transplant, like with gilteritinib. Could be an acceptable strategy, but still we lack of long-term, and we don't know the impact of potential maintenance in a second line after transplant with monotherapy. But we have to go to the front line. This is clear with many inhibitors, FLT3 inhibitors, combinations between them. We have to keep very cautious in older patients, giving quadruplets and these kind of things. But I think that fit patients, they can tolerate in a smart way the combination of 3+7 plus 2 different targeted agents. And there is one trial that I did not comment to you that we will perform. The name is Intenso, okay? It's intensive chemotherapy plus enzomenib, and this is a 3+7 plus quizartinib plus enzomenib for some patients, not for all.
Thank you. Yeah, I'm sorry, this is sort of directed back at Pau again. I mean, the Apollo study was fantastic, and I think that the world probably does believe, and certainly we do in the UK, that this is defined a new standard of care for high-risk APL, and thankfully for that data, we're now able to deliver that treatment off protocol. I just wonder about the patients that didn't have arsenic as their frontline therapy. Were they difficult to salvage from their chemo-atra-based schedule when they relapsed? And did you have a strategy within the protocol looking at MRD by PCR to evaluate them at an early time point, perhaps?
Okay. Unfortunately, the Apollo trial had a low sample size. When you look, it's 65 versus 65, and very low rate of relapses by the end, even in the AIDA arm, with high risk AIDA arm. So I think we will not be able to draw any conclusion regarding your question from the Apollo trial, and I'm not aware that this analysis will be performed. Okay, I hope that some further analysis and publications will be done from this trial, but I'm not aware about this. I remind patients treated in my institution in the Apollo trial high risk, and they are cured and they perform very well. So still, it is a very good option. Your question is very pertinent. Why? Because we will not have easy access to arsenic trioxide to all our patients, high risk, because it is nobody will license this. So it will be, we don't know how we will manage. And you see that we have a new standard of care, and we did not amend the protocol. We have to do a new protocol based on the Apollo results, but we are not able to do yet. So there is the other way, is like you did in the NCRI study, the UK study, is give AIDA frontline and then salvage with arsenic trioxide and ATRA. This is what we have now. And we have a very good outcomes for a relapse setting, okay, with arsenic trioxide plus ATRA. and 1 or 2 consolidations, and then autologous stem cell transplant. Okay, so the rate of complete remission is there is no resistance with Atrato in the salvage, in the first salvage. There is no resistance, and there is 90 was 100%. I don't like to say 100%, but the numbers were small. But with both drugs together, was 100% of molecular remission in the relapsed refractory setting. This is the experience of PETEMA, more than 150 patients. So many of them, they could undergo autologous transplant, and the survival after autologous transplant with MRD negative is 75%. So it's a curation strategy still to salvage patients in that way.
I would like to comment on this discussion between Natalia Baron and you, that though it is a selection prior to the clinical trials, and those papers which has been published are being compared with other ones being published either. So in a sense, it's this confusion between the clinical trial analysis and real world isn't in a sense between those researchers. And the other one, sorry for Eddie's comment, it was about guidance. And once I attended a conference, it was a huge hematology meeting, and one colleague from Canada, Polish origin, who is a participant on many guidelines, he had a lecture about guidelines. And he said, and I do agree now, being involved in many of them, that there are a few quite strong personalities, good in the field. And then each of them is showing, their comment, their view on the same subject, giving literature, background, everything what's needed. And then when it comes to last version, many of them, they forced their ideas and blow up their particular detailed something. And eventually, the guidelines is full of important statements, but nowadays is not do this, do that. Suggestion, you may eventually think about something. And he said, in conclusion, that actually at the very end should be hematologist practitioner. They see it does change his approach to diagnostic procedures, to treatment, and actually assessment of the patient, and it's not far from the truth.
Because I'm leading guidelines, so you hear me? Yes, I absolutely agree with what you say. Okay, the problem comes when the persons that are doing these guidelines and they are subtly imposing their vision in the guidelines, when they believe that this is the best. Okay. I think that it is important to remark that the guidelines are not done just because we believe that this is the best approach to the patient. Okay, they are made because we want to offer homogeneous approach to patients, and we want to avoid that each hematologist is doing different things. Okay, because each hematologist can consider himself that he's doing the best. Not only the one that is leading the guidelines, but each one. And even I would say more. One hematologist can say that he's doing the best one day, and the day after, it changes. Just because there is a manuscript, or just because some experience of somebody told him something. So what we want to avoid with the guidelines is variability, acknowledging that this is not necessarily the best approach for the patient. And this, if you are able to transmit this to the people, okay, they will know that, of course, they are, let's say, free to apply the guidelines in the best way in their ambience or in their daily practice, okay? And the second point of the guidelines is that if we implement new approaches and new strategies for our patients, after 3-4 years, if we are following this approach in a homogeneous way, we will be able to measure if really we had an impact or not. If not, it is impossible. But I agree that it's like looks like it is a democracy. I fully agree with this.
I don't want to monopolize the discussion, but I have another questions to Professor Podolek-Dawidziak regarding procoagulatory states. Would you consider, especially when you were showing, okay, APLs definitely are usually like associated with hemorrhages, but in non-APL and in non-APL AMLs, there is definitely huge heterogeneity between, right, let's say hemorrhages or procoagulatory thrombosis risk. Would you consider in this group of patients from or upfront, you know, screen for JAK2 mutations, giving, you know, like this emerging evidence about, you know, coagulation changes during or triggered by clonal hematopoiesis driven by JAK2?
We shall travel through all hematology almost together. But it is so that acute myeloid leukemia being there as an example, actually to show changes in APL, because it shows a heterogeneity in a sense that it can be this score can be go from small one up to high one, and in APL starts with the higher. But this what you this your second part of the question. JAK2 is, as we know, that JAK2 can be positive even in so-called healthy subjects. Especially, we shall be careful when it's unusual placed, some thrombotic complications. But JAK2 positive patients, they have other independent prothrombotic factor, which is white blood cells higher than 11 gigapiliter. Then if they have, doesn't matter positive or not positive or MPL positive, when it's a platelet count higher than 1,000 or 1,500 gigapiliter, they are prone to hemorrhagic complications due to acquired von Willebrand syndrome, or there is another reason for thrombotic complication, those leukothrombotic thrombi, let's say this, which block smaller vessels. So it's interesting story and definitely worth checking, but it may apply eventually to AML, even it will transition from essential thrombocythemia neoplastic disease to acute myeloid leukemia.
I'm really sorry, but we need to stop the discussion. But if you would like to continue in discussion, I invite you to ask many more questions during the lunch. So we have to follow Jovita downstairs just to have a short break, and then we continue with the meeting. Thank you.
Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku, nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie.
Continue with the topic of AML, but we are going to dig a little more about the pathology, about the clonal evolution, MRD, and artificial intelligence. So with this, I'd like to invite Professor Artur Kowalik from Kielce, who's going to speak about genome secrets in AML, MDS. Please go ahead.
First, I'd like to thank you, Professor Sobaś, for the invitation. It is great to be here, and I'd like to stress that my lecture will be boring comparing to previous one because it was a great lecturers and great information. As we know that AML is a clonal disease. Of course, it has a clonal path of development starting from hematopoietic stem cells, and then there is some kind of scientists suspect mutations, or some are inherited as a germline, and then it causes that is the clone advantage. So clone advantage means that there's a high proliferation, and high proliferation means that there's a high inflammation also. And this means that another mutation are acquired. And finally, we have three types of development, one for MDS, NPN, and directed to AML, and one heterogeneous, I mean that MDS, NPN. And then we need second wave of mutation and genetic, which cause extend genetic instability to appear to finally appear as a secondary ML. The clonal path is really interesting. As I said, firstly, there are some kind of patient which inherited the mutation, and which is really, really important. You as a clinicians obtain the report when you can see sometimes results with mutation with a very high variant allelic frequency. It means that if the variant is high enough, more than 40%, you can suspect the germline mutation in this listed frequently mutated genes like DDX41 and the rest. I'd like to stop here for a second, because in our country, unfortunately, there is not so many clinical geneticists, so the genetic counseling for patients with oncohematology disease is almost inexistent. So this is the real challenge for the real future. We need some changes in the policy. Probably we'll need the new people in the team, like it is in the, for example, in the UK, the genetic counselors, because it is so many people who obtain the test which suggest inherited mutations. And this is the case also in oncohematology. And of course, the next, the clonal hematopoiesis, the phenomenon relatively lately discovered. It is also connected with cardiovascular disease and many others. And then we have clonal cytopenia of undetermined significance, and then finally myeloblastic syndromes. And mostly the differences is in the number of blasts. And finally, it appeared as acute myeloid leukemia with many different kind of mutation, genetic diversity, and blast more than 20%. And this is the lately published, I think, a few days ago, paper which was based on more than 300 patients with AML from 70 institutions at the diagnosis point and complete remission. The results, they detected mutations at least in 5% AML patients, which is really a huge number. And the more than 60%, at least almost 60%, it was the DDX41 gene which was mutated. And going forward, the molecular landscape of MDS is that we can say that mutations connected with MDS are with splicing. There are few genes which are well known. Then with epigenetics, transcription, and signaling. And I think that the signaling will be a crucial point in the future time. We need to develop more drugs which could stop, for example, activity on RAS genes, which are really challenged in the solid tumor, also in oncohematology. I will show you later some information why it is important. And of course, mutation in NPN. So the first one hits like JAK2, CAR, and NPN1, and the secondary mutation like an IDH1-2 and as ASLX1. And of course, the mixed phenotype, which is accumulation of mutation from both spectra. And the risk of progression, we know that about 40% of patients with MDS finally will progress to AML. And there are, of course, some high-risk MDS, which progress even in the level of even higher, so 50%. And in the NPM1 is wider diversity, so within 10 years, it's about 5 to 20% patients will progress to AML. Of course, from the risk is for essential thrombocytopenia 3%, polycythemia vera 14%, and primary myelofibrosis still 20%. And what is really interesting here, as you can see, that the most progressed cases are from MDS, but we can also be aware that the secondary AML based on the treatment, successful treatment in the past, for example, from breast cancer, there is a growing number of patients which are coming to the clinics as a patient for hematologists. And the disease is very aggressive, and this is why we need to genotype patients if we think about the germline mutation, because there are some data which stress that the patients, for example, with breast cancer, some kind of chemotherapy should be avoided if they inherited germline mutation which predisposed to acute myeloid leukemia. So this is really important. As I said, we need some kind of national program to start wider genotyping our oncohematology patients regarding to mutations which predispose to familiar cancer. And even you can detect familial predispositions in patients which are in the years of 60. So this is not also connected with patients which are really younger generation, 30, 40, but even older. So this is what is really, really important. And once again, if you obtain the results from NGS and find some results with these genes I just showed, you should check what is the allelic frequency in this report and ask about any kind of tumors, oncohematology tumors, or any kind of disease in this family. But the question is, for example, if we will be able to check the mutations, for example, in children of this kind of the patient, and we confirm this mutation, so what to do with these children in our country, yes, and where when to send to children hematologists, and what he or she should do with this patient, because I don't know if there are any guidelines which could, for example, lower the risk of, for example, any kind of hematologic disease in the persons which are carriers of these mutations. And of course, the clonal pathway for myeloproliferative neoplasm is, as I said, the JAK1, CAR, or NPL, the first hit, and then it makes that the clonal advantage, the cells proliferate in the fast way, and then self-enforcing. Like I said, that it is connected with inflammation also. So from the textbook, we know that mutations to appear to exist, it means that the cells must divide. So if DNA change, but cells do not divide, there is not any risk to develop any kind of cancer. But the problem is, if it is extra inflammation, and inflammation make this that cells start to division. So this is the real problem in that time. And the secondary mutation which are acquired, and finally TP53, and then it finally ends with failed immunosurveillance, and leukemic stem cell clones develop. And what are the main difference between the MPN and the MPN progress to blast phase? As you can see, the frequency of mutations are high, and the allelic frequency is higher. So it means that in the human body are many more cells which possess this kind of mutation. So like I said, epigenetic modifiers, splicing regulators, cell cycle checkpoints regulator, cell signaling pathways. As I said, these are really challenge, and I think company which will be able to develop the inhibitors for this kind of proteins, I think it will be the next breakthrough in NPN, and of course in solid tumors also. I know this is for overall survival, it has a negative impact, and if we, for example, could apply some kind of treatment, so as you are aware, we can, for example, apply IDH inhibitors, which could, for example, prevent or make progression slower. And regarding to MDS, we have several subtypes of MDS, and the clinicians are aware of prognostic scoring systems, IPSS 1997 based on clinical cytogenetic, IPSS R revised clinical cytogenetic model, IPSS molecular, so widely accepted and used clinical molecular prognostic model, which includes a few 6 categories, and some kind of novelty, machine learning, applied machine learning to the data, and I think it will, we can expect in the near future probably the some kind of revolution in this kind of applications. And I'd like to present some data from the paper, which was based on more than 3,000 MDS patients, MDS, classical MDS, mixed MDS, MPN, more than 500. And the authors was able, based on 152 genes mutated, to divide this group on several categories. And what's really interesting in these results that, as you can see, the category AML-like and TP53 complex means that the overall survival is very, very short, comparing to no event called subtype or SF3B. Of course, the range is not so good for clinicians to introduce to the practice, but on the other hand, you can see the rate of AML development between 1 and 3 years. You can say that the risk is really, really lower, as you can see, comparing to this to 1. So what does it mean? It means that we need more data. We need to apply to MDS next generation sequencing, maybe exon 1, to be able to discriminate more subtypes in this heterogeneous group. And also, they were able to correlate this data with blast percentage. As you can see, AML like the more one, but not as high as 50%, and of course, the mentioned earlier, the blasts are less than 2%. And overall survival, of course, in MA-like, correlating to blasts are lower, comparing to these subtypes which are higher. But still, the range is not so good to introduce to the practice. So the question, comparing this picture with the previous one, probably that blasts are not so good predictor, because if we think about the statistical range, we can see that it is lower if we only make the prediction based on the mutations. And the nicely divided and pictured the mixed phenotype MDS NPM1, as you can see, still there is a wide heterogeneity in this subtype. The scientists claim that in this subtype, first mutation characteristic for MDS appeared, and as a second wave mutation which are characteristic for NPM appeared in this stage. And to summarize, as you can see, that the these three types of diseases, so MDS, NPM1, and de novo, have some strikingly different pathways. Of course, in the red are pictured chromosome abnormalities. As you can see, they are different. And what is characteristic that for these two, which is more often appeared as a secondary mutation, TP53. And of course, mentioned earlier by me, the real challenge for the clinicians is therapy related. So people who were successfully treated, for example, once again, with breast cancer, women are living, there's a growing population, people who live longer after the breast cancer treatment and any kind of non-oncohematologic cancer. So we could expect that in the future, this population will be growing and it will be a real challenge for you in daily practice. And last but not least, I found I was looking some nice and catchy paper to present, and finally found a single-cell multiomics in MDS treated with hypomethylating agents. The group was not so big because it was only 14 patients treated, but applied single-cell sequencing and protein profiling. So it was like a targeted 53 genes only and plus 42 surface proteins, and they were assessed 19,000 cells in the whole group, which comes from the 14 patients. What was really, really interesting, so most patients had mutation epigenetic regulators, not novelty, transcription factors, not novelty, splicing genes, not novelty. Here are responders, and here are non-responders. There's one difference I mentioned earlier, that they could not find any mutations in the NRAS, and so classical oncogene and 2 tumor suppressor genes in the group which responders to the hypomethylating agents. I know the group is not so big, so we, in the future this group should be extended, but this is why we need some special inhibitors to treat effectively this patient, because this patient did not have mutations in classical oncogenes in tumor suppressor genes. And it could be really interesting if you as a hematologist could apply. I'm not aware if any kind of studies are conducted, because in the treatment of malignant melanoma, there is a MEK inhibitor. The protein MEK is below the NRAS cascade. So maybe adding here in this group, the MEK inhibitor could make some kind of changes, because these patients has mutations in the NRAS cascade. And of course, PTN is a tumor suppressor of another pathway, PRK3-AKT pathway, which is also now blocked by any kind of small inhibitors, which now probably introduced also in the breast cancer as well. So maybe it could make some changes. And what was interesting from these studies, the 3 clonal evolution patterns, shrinkage of mutated clones, responders. As you can see, after applying hypomethylating agents, finally all clones died, or were almost removed. As you can see, the linear evolution of the clones, and the second pathway, stability or expansion clones, non-responders. So there was some kind of clones which not respond to the treatment. And as you can see, the patient 4, there was the branching evolution. So was one clone with TP53 mutation and one with NF1, both tumor suppressor genes. And the third, stability or expansion clones, emergence of new clones, non-responders. So this is the, help. I almost done. Sorry. And this is the classical pathway of resistance, yes, that we have some multi-clones, appear new one, and disease after the treatment still is composed of multiple clones. Here you can see that there was any kind of response, and during the treatment you can see that there was also some kind of appearing new tumor clones. And what was interesting from immunophenotyping, they were able to find that post-treatment depletion of specific types, they find that in the responders disappear hematopoietic stem cell and progenitor cells and common myeloid progenitors and in major granulocytes and monocytes. As you can see, at diagnosis there are these groups of cells, and in patients with successful treatment with hypomethylating agents, this group of cells almost disappear completely. So in the responder, so the treatment is effective to kill the cells which are responsible, which fuel the whole of disease. And here you can see the situation in the particular patient which responded well. So completely, almost completely, cells disappeared, progenitor cells or hematopoietic cancer cells. So this was that the hypomethylating agents were successful. And clinical implications, so I think that in the near future, single-cell sequencing will subsidize classical flow cytometry, if it will cheap enough, because it brings many more information in different kind of levels. And of course, as I said, this data shows that some kind of RAS inhibitors, of MEK inhibitors, especially MEK, which are widely well known in the clinic, could be applied and could make some kind of changes. And I think this is also the target, how to change inflammatory microenvironment for the future clinical trials. And of course, other candidates could be applied to treat the non-responders. And conclusions, for me the conclusion is that it is great that in our country many more clinics use NGS-based testing. We need it more. I heard in the previous lecture that colleagues from Spain are able to deliver 48 hours, 5 days, yes, NGS-based results, which is sometimes we can do the same, but not always. Usually it is more than 2-3 weeks. And I think that in the future we need more single-cell based studies because they can deliver us more information and bring us, I hope, finally the clues how to effectively treat this multiclonal disease. And also we can't forget about the profiling global methylation in the near future. I hope that the technology will be cheaper enough soon to be applied widely in the clinic. Thank you very much.
Thank you very much. And now we move to MRD. Professor Michael Dennis from Manchester, please, your floor is yours.
Okay, thank you, Marta, and the organisers for this kind invitation to give you a little overview of perhaps how we approach managing acute myeloid leukemia from the UK perspective. It's been great to have a number of talks already today which have use of some of the NCRI data, and I'll be touching upon elements of that. I called it train spotting. I found this whole idea of having a meeting that had film themes unusual, but hopefully a lot of fun. The idea really being that with acute myeloid leukemia, you've got to identify those patients who are going to have a disease that's going to be difficult to manage, difficult to control, and run down the rails out of control. And I think that we've got some challenges with AML as well in relation to relative lack of good, effective therapies. You'll see a lot over the next couple of days about how various new treatments have transformed nearly all other blood cancers. But the changes that we've seen in relation to acute myeloid leukemia have been relatively modest in terms of how they've changed quality of life and also survival for patients with acute myeloid leukemia. And by the way, the last talk, I mean, I don't know, maybe I don't understand Polish humor. You thought it would be boring. I actually really thought it was fascinating. Thank you. So I have no significant disclosures to make in relation to this talk. Train spotting. I don't know if this is a big thing in Poland, but it used to be quite a thing in the UK. You'd get mostly males who would spend their evenings and weekends on train platforms, carefully photographing, logging and documenting locomotives travelling all around the British Isles. It certainly was very popular in the 1980s, and I think with the internet there's a sort of a resurgence in terms of how you can interact with your colleagues. But that wasn't really the train spotting in terms of the theme. I hope some of you have seen this film. I think it's a great film. There are many theories as to why it's referred to as train spotting. Probably don't have time to go into that in too much detail, but it's one of the films that really launched Ewan McGregor and the director Danny Boyle on the sort of global stage. Series of really important films. It's based around a group of heroin addicts in Edinburgh in the 1980s. I'm from Edinburgh, was brought up there in the 1980s. Hopefully my drug misuse more relates to chemotherapy rather than heroin. But it is semi-autobiographical, and I felt it was absolutely the theme for my talk today. In line with what we've heard from Spain, this is our typical sort of approach in terms of when patients are presenting late on a Friday with suspicion of acute myeloid leukemia. Our teams would be rapid in terms of confirming the lineage by means of peripheral blood or bone marrow morphology and flow cytometry. We have a working 5-day turnaround for PCR or fragment analysis or a limited panel of NGS-type based tests, and also targeted FISH and cytogenetics that we should give us a fairly clear idea within that first week as to what the underlying problem is likely to be. And then once you've selected therapy, whilst patients are undergoing their first cycle of chemotherapy, you'll get the more extended myeloid panel back to guide you in terms of second cycle of treatment and so on. So I think we've seen equivalent slides to this already. It really just gives you an overview that over the last 7 years, there's been a fairly dramatic transformation in terms of the agents that are available. Many of them that can be applied across the board, or they may be targeted, but almost always in the European or UK setting, these are frontline therapies that are making limited impact for the AML patient as a whole. You'll have seen this type of approach in terms of understanding, and I think the work that the European Leukemia Net do in terms of their guideline writing can be very informative in terms of framing the outlook for patients with acute myeloid leukemia. And you'll already have heard how the favourable patients with core binding factor, isolated NPM1 and BZIP-inframed CBP alpha, these generally respond well to chemotherapy and don't usually require allogeneic transplant. Conversely, the patients who have more adverse type cytogenetic features or molecular features, they tend to be less responsive to treatment and tend to more frequently require allogeneic transplant. But these are a guideline, an outline. You'll know that when you're treating these patients within your clinic, it's often somewhat more varied than that. And I think that's where MRD can be useful in terms of trying to understand where this train's going. So MRD is really a reflection of chemosensitivity. And this was a study that we published some years ago now in 2016, really looking at bulk changes to initial cycles of chemotherapy. So it was taking historical trials that we'd performed within the UK and looked to see what the response was in terms of remission status after 1 or 2 cycles of treatment. And the message really is that if you've got a chemosensitive disease, survival is better. We all know that. And as a general outlook for patients that were in our trials at that time, about 40% of them who'd responded to that first cycle of treatment irrespective of anything else, were alive at 5 years. You can see if you achieved a partial response in blue, or the lower lines where they achieved a complete response after cycle 2 or never achieved a complete response, the survival, irrespective of what you do in terms of intensive chemotherapy and transplant, remains very poor. So with respect to Pao, who's one of the authors of this paper, our progress in terms of treating relapsed disease is terrible. You know, gilteritinib within the last 7 years is the only new agent really that's been licensed within the UK or Europe to be managing patients, and this is patients of all ages who have got FLT3 mutated disease and at relapse either had salvage chemotherapy, that might be intensive chemo such as DA, MEC, FLAG-IDA, or non-intensive therapies versus gilteritinib. And although the study met its primary endpoint, the fact that hardly anybody's alive 2 years down the line, despite the fact they've had this salvage treatment and allogeneic transplant, really is a message for us that we need to be doing more in the relapse setting. We've got to identify these patients earlier. So a lot of the data that I would talk to you about really is sort of building upon our recent findings within the NCRI studies. So for the last 20 years, I've been involved with the NCRI group in terms of designing and delivering many of these AML trials. And it's a great honor to be presenting some of the data in line with some of the features that we've seen already today. ML19, for the uninitiated, was our study that's recently closed in relation to patients under the age of 60, so our young, fit population who would be treated with intensive forms of chemotherapy. So you'll see in the standard risk group, which is the majority of the patients, there's about 1,000 patients who went into this randomization between fairly conventional approach for us, DA with 1 dose of Mylotarg, versus our more intensive schedule of FLAG-IDA with the Mylotarg single dose or 2 doses. The average age, 51, and this is the evaluation when you look at the primary endpoint. So if you give 1 or 2 doses of Mylotarg with your induction chemotherapy, there's no impact in terms of overall survival. If you give FLAG-IDA, far more intensive schedule versus the conventional DA, which is like the 7+3, but with a few more days added on, again, no impact in terms of overall survival. So you might think that's pretty disappointing. You know, our primary endpoint wasn't necessarily met within the study. I think the things that at this point you'd highlight that are doing particularly well is that the survival in this group of patients, the plateau off in the Kaplan-Meier curves, is really quite encouraging, whatever treatment patients were given. And I think this highlights the fact that appropriate diagnosis, improvement in supportive care, and maybe the impact of MRD. So if you look at the molecularly defined subgroups, and I think you saw this data earlier on today, if you look at the FLT3 mutated subgroup, who we've been historically thought not to be patients that would have a particularly great outcome, the standard of care is DA with midostaurin. The 5-year survival rate with DA midostaurin is 50%. So within this trial, which is again looking at same group of patients under 60s, FLT3 mutated who are fit for intensive chemotherapy. And the 5-year overall survival rate there for FLAG-IDA is 64%. So it seems to be comparing favorably. If we look at the NPM1 subgroup, which we predominantly think of as good risk disease, more likely to respond to therapy, we're then seeing a 5-year overall survival rate of 82%, which I think is unreported to see survival that's that superior. And again, raises the question, what is it about these patients within the study? We always draw parallels and understand that patients that go into clinical trial don't necessarily equate to the type of patients that are always pitching up in your outpatient clinic. But these are cooperative group study where the majority of patients under 60 with acute myeloid leukemia within the UK would be going into these trials. The exclusions were not particularly tight. We've had a long-standing interest in terms of the utilization of MRD, and you'll know that really NPM1 subgroup by molecular means are really the ripe fruit that can be picked in terms of being able to evaluate in quite a robust way. So this was work that was written up by Adam Evie under the supervision of David Grimwade, highlighting and published in New England Journal the fact that MRD negativity correlates with survival. Relatively small numbers of patients, but you can see the survival in the MRD negative was 73%, survival in MRD positive was 24%. And this relates to the frequency of relapse. We did a lot of work during this initial study, this was AML 17, to evaluate which were the key time points to be assessing MRD. You don't want to do MRD in the blood and bone marrow at every opportunity. So the most sensitive signal appeared to be looking in the peripheral blood after the second cycle of chemotherapy, which is the discriminating time between positivity and negativity. So when we look at AML 19, we're sort of interested to know what the combination of FLAG-IDA Mylotarg might possibly achieve, high levels of diagnosis, and I hope this is reproducible. You can see that within bone marrow, you're seeing a dramatic improvement in terms of achieving MRD negativity by the escalated treatment of FLAG-IDA with Mylotarg. And then our discriminating factor as to whether a patient should have a transplant or not, your MRD negativity has gone from 76 to 88%, which is highly significant. So we then wanted to look at this in a more prospective manner in the AML 19 study, really to sort of evaluate, is all NPM1 mutated disease favourable risk? Well, the majority is. Clearly, if there's a co-mutation with FLT3 ITD, there's a feeling that that would be intermediate disease, and then you'll get patients with an adverse karyotype where this probably overrides the presence of the NPM1 mutation, and they perhaps have adverse risk. So this could guide us in terms of decision-making following the second cycle of treatment as to whether the patient should have allogeneic transplant or not, perhaps irrespective of the initial genetic makeup or other features with respect to the patient. I think I've largely covered that. Oops. So this is consolidated data between the two trials, sequential randomized trials for younger patients with acute myeloid leukemia. I think it's important to mention that this is, although there was an analysis to look at the incorporation of FLT3 inhibitors at the time, that wasn't a key part of this part of the trial. And it was prior to the marketing authorization of midostaurin. So patients predominantly within this study didn't receive FLT3 inhibitors. It's really a trial of intensive chemotherapy and antibody. You'll see the sort of numbers of patients that you need to reach statistical significance in this type of analysis. We had about 5,000 patients going into this study. If we just focus on the right-hand side, it sort of gives you more of a clearer flavor in terms of how this all breaks down. You'll see that, and I would hope most of you would know, NPM1 mutation occurs in around a quarter of patients in a younger setting with acute myeloid leukemia. We've got a really impressive CR/CRI rates after 2 cycles of treatment of 94%. And then the majority of patients within the protocol setting have been able to have peripheral blood and bone marrow MRD samples suitable for analysis. And you'll see the MRD negative, very few went on to a transplant. MRD positive, the clinical message was going out, give transplant. If you look at the overall survival and the impact of transplant in all of the patients as a whole, there's absolutely no impact. So transplant doesn't seem to benefit per se. However, if you then look at the patients who are peripheral blood, NPM1 positive, after second cycle of treatment, there's a dramatic improvement by the presence of a CR1 allograft, with survival going from 20% to 60%. And this relates to the quite marked reduction in terms of relapse risk as a consequence of allogeneic transplant. And I know that that's a key message that people should always be getting across. There's really no more effective treatment for AML than an allogeneic transplant if it can be safely delivered. Contrast that, though, with the MRD negative setting. So here we're seeing that those who are treated with an allograft in CR1, no change in terms of overall survival. But relapse was reduced by allografting these patients. This is a really difficult point in many ways because although your individual patient may have achieved MRD negativity following their second cycle of treatment, they still arguably have a near 30% prospect of relapse. And historically, as we were saying, salvage treatment could be terrible. I guess in the NPM1 setting, venetoclax-based treatments or menin inhibitor-based treatments may enable less intensive salvage to improve outcomes for these patients. But it's a very nuanced and complex discussion you need to be having to your patient. And it does require the fact that you would need to be doing regular NPM1 molecular monitoring at the cessation of therapy to be able to timely identify these patients whom you know 1 in 3 are going to relapse, require salvage treatment and allogeneic transplant. If we look at all the multivariable analysis to see which are the key indicators in terms of survival, older age, a high white count, adverse carrier type, a non-ABD NPM1 mutation, DNMT3, FLT3 ITD and WT1 all have an adverse effect, but none of them is the effect as strong as MRD in terms of outcome prediction. So that's in the upfront setting, and I think other data that we've collaborated with the Australian group really would look to see, again in the NPM1 setting of patients who've been treated intensively, do they have molecular persistence or a molecular relapse, and what happens to them as a consequence of identifying these molecular changes rather than waiting for bulk relapse. You'll see the response rates in the patients as a whole pretty good, and not surprisingly, those who are wild type for ITD have a better response than those who have the ITD mutation. And in the cohort of small number of patients, survival from a relapse setting or molecular relapse appears to be good compared to historical control, and that's split out in relation to the presence of ITD or not. You'll know that NPM1 evaluation by molecular means is also quite useful in terms of how you deliver your treatment from a non-intensive setting as well. VIALE-A has been quite a disappointing study in that although it transformed care and 70% of patients will have a response, it eventually plateaus off with survival at 4 to 5 years of just 10%. It's almost certainly that the overwhelming majority of those patients are those with an NPM1 mutation in the absence of other complex features. But you'll see that the responses to achieve MRD negativity in the context of venetoclax-based treatment is a bit slower. So on average, you're really looking at 4 cycles in before you've been able to make a definitive decision as to whether the patient's going to achieve molecular negativity or not. This does relate to survival and does have a phenomenal impact in terms of the potential for relapse. But I think it also guides you when you're troubled by these patients who've got significant cytopenias, who are struggling to regenerate. Knowledge of the level of remission, particularly the molecular remission, can give you, a key insight as to how intensive you should be in terms of venetoclax dosing, duration, and the frequency at which you're delivering these cycles of therapy. Pao mentioned this. In the UK setting, we sort of feel that core binding factors probably concluded from our perspective. It's a relatively rare form of acute myeloid leukemia, so the numbers are not huge. But within the context of this trial, we basically looked at escalating doses of antibody and escalating doses of chemotherapy. And we found that the 3-year overall survival for patients in this trial was 97% for those who had the least intensive approach, so the DA with 1 dose of Mylotarg. It's not wildly different from what we were doing in our AML-17 study. And there are only a relatively small number of patients that relapse or don't respond optimally, but molecular monitoring likely plays a key point in early identification of patients who are not achieving their time planned goals from a molecular perspective, enabling treatment at molecular relapse and allogeneic transplant for a very small group of patients in that context. This was data that was presented at ASH by Jad Othman and it's been published in Blood this year. Again, consolidated information from the AML-17 and 19 study. And KMT2A is highly topical at the moment because of menin inhibitors, but we were interested to see, was the adverse impact of KMT2 rearrangement genuine and borne out in this younger cohort of patients? I think the answer to that is yes, the survival is only 38%. Within the context of ELN, everyone always remembers that the T911 form of the disease falls into that intermediate group, but people often think, is it really intermediate? And is it only there because the data sets that ELN have taken the information from are largely underrepresenting the numbers of patients with 9/11 translocation? In terms of survival, there's a very modest output here with slight improvement in relation to compared to KMT2A of all other varieties. But there are probably two key points that come out of this evaluation. One is that FLAG-IDA, we believe, is unequivocally the standard of care. The overall survival is doubled by having intensive chemotherapy, FLAG-IDA versus DA treatment. And this is related to the marked reduction in terms of relapse. So in our hands, we believe that FLAG-IDA really should be considered as the frontline therapy. I think this makes it quite challenging when you're looking at future studies that are looking at menin inhibition and combining that with DA-based treatments. But that's a challenge for us as a community that we need to embrace going forward. The other key point is in relation to the utilization of MRD as appropriate for this talk. That you'll see here that patients who achieved MRD negativity, again, in the peripheral blood, post-cycle 2 of chemotherapy, survival was very, very good. If after 2 cycles of treatment you're not MRD negative, virtually all of those patients are going to die. And that's irrespective of whether it's a 9/11 or an adverse translocation. So MRD negativity is more capable in terms of predicting relapse and might guide you. So if your patients are still MRD positive after 2 cycles of treatment, it may not be ethical just to plow on with an allogeneic transplant, certainly in the context where there may be salvage, such as menin, that might improve the outcome thereafter. Most of what I've talked about has obviously been in relation to molecular studies, but obviously many of the patients don't have stable molecular transcripts that you can quantify. So what do we do in those patients? Well, flow cytometry has been established as a way forward. This is data from Sylvie Freeman. I've had to dust down 1 or 2 slides for this talk, but this slide's going back 12 years. And it highlights the fact that if you take a slightly older group of patients over the age of 60 who are fit for intensive chemotherapy, and you do a bone marrow evaluation by flow cytometry looking for a leukemia-associated immunophenotype, that it does correlate with the probability of relapse and the probability of overall survival. These are only modest differences. I think it's important to highlight the fact that the kinetic of it, so relapse in those that remain MRD positive post-cycle 1 is occurring at a very, very early time point. But it does give you an insight as to what you might want to do about that. The survival in this older group of patients is really, really poor. So what should we be doing to improve that situation? And that's where our future study came in, AML-18. So it was running in parallel to AML-19 study. Weirdly, historically, we always had this sort of emblematic cutoff at 60 that many AML trials have. So this is for the over 60s study. It was comparing DA as induction chemotherapy with 1 or 2 cycles of Mylotarg, evaluating the response, so the chemosensitivity of the patients after that first cycle of treatment, and randomizing patients between just continuing on with our second induction schedule, or whether you would escalate the treatment to a FLAG-IDA-based approach, or by adding cladribine. We were conscious of the Polish data, which supported the idea this has got a utilization within the context of acute myeloid leukemia, and thought that this might be something to improve the outcome for this group of patients. And I think what this has shown is a clear evaluation that, so for patients who were MRD positive following their first cycle of treatment, if they were randomized to DA with the addition of cladribine, you can see that survival significantly improved. And the same is true if you escalate the treatment to FLAG-IDA-based approaches. But the cladribine is certainly better tolerated, and certainly the benefits have been established even beyond the evaluation of what allogeneic transplant can achieve in this group of patients. So I think it's clearly identifying patients who have got chemo-refractory type disease where you want to think again prior to ploughing on with allogeneic transplant. So this brings me back to train spotting. More modern trains, the Intercity 125 in Paddington Station. And many of you will know that this work in terms of MRD, certainly from the UK perspective, was developed by David Grimwade, who's been recognised as one of the founding members of the ELN MRD Working Party. David, sadly, was an amazing guy who died all too young at 53 back in 2016. I suspect many in the audience have had some friendly and hilarious interactions with David. And it wasn't until actually we were at the celebration of his life that his parents actually revealed that David was an avid train spotter back in the 1980s. That attention to detail of registering the journeys of the transportation around the UK, he applied to meticulous MRD tracking, initially in APL and then ultimately in NPM1 mutated AML as well. So, summary slide. I hope I've made a persuasive argument that qPCR for NPM1, peripheral blood post-cycle 2, identifies patients who you should be considering for allogeneic transplant or not. I think that bone marrow peripheral blood is helpful in terms of salvage treatment for those who've had suboptimal therapy to intensive chemotherapy and can improve longer-term outcomes as a consequence of that. I think it is standard of care that qPCR for NPM1 is also able to guide low-intensity treatments we talked about. qPCR is pivotal if you've got laboratory access to this in terms of evaluating what you do for your KM2T rearranged patients. And then flow MRD. Well, why is it that that original publication in JCO was 12 years ago and in fact, flow MRD is not widely implemented in practice, but we've got clear evidence from this most recent study that identification of chemoresistance creates an opportunity for escalated therapy and an improved outcome for patients. And then really just a final word, look out for ELN David. It's the new guidance that's coming out later this year. Thank you.
Thank you for a brilliant talk. And now we move to artificial intelligence. Can we diagnose, predict AML with this? With artificial intelligence. And my friend Amin Tarki from Essen will give the lecture. Please, Amin, the floor is here.
Dzień dobry. Thank you very much for having me here. Okay. I'm very happy to be here and to see so many young people here in the crowd and to follow also this very interesting set of speakers that has come along and brings together I think the most important, or many important issues that we're currently facing in myeloid, but also tomorrow in lymphoid leukemia. We just heard the relevant impact of MRD for the treatment assignments and also for the treatment follow-ups and the treatment management of our patients. I was given this title, The Matrix of Leukemia, so it was not my own choice to decide it. But I think what this is pointing to already is what the question is: how can I contribute to see the truth? I was already introduced. I'm a physician scientist, so on the one hand, I'm practicing as a hematologist, but I'm also a researcher in data science. And this was, of course, the answer following that title. So this is what we can see here. What can we see in the matrix? And I think something that you know very well, and you don't need to look at a matrix, is that nature hides its secrets, and whether you try to approach those secrets with data science efforts or with molecular understanding, with clinical trials, is something exactly to address this question. And giving the question of this, or giving the title of this talk, I think the focus of AI will be more on the question of how to utilize unsupervised learning in order to dissect data sources from a different angle. You are well aware that there are also other possibilities in order to prediction models. This will not be a focus of this title, of this talk. We are living in a time that I consider a time of unique opportunities, which are synergic. And on the one hand, we have a transformation, digital transformation, but also technical transformation. It was mentioned already from the point of view of MRD, also in the greater abundance of sequencing technologies that enter our routine practice. We are enabled also to harmonize those massive amounts of data that we generate from those endeavors. We have common standards that have been established over the last years. We have also been utilizing and implementing these standards more efficiently and integrate now also data from multiple sources. We have also technical advance in terms of AI tools. You're well aware of the use of large language models because they have been integrating your daily life in part. But we also have possibilities for data augmentation, so synthetic data creation. Those are all possibilities that can respond to our need as hematology community, so as doctors. And last but not least, to mention also the mobile devices that have been, for instance, also profiting most of our colleagues in the endocrinology departments and patients, just very short. My previous speaker has also complained about the lack of new therapies, and I agree with him. But in other certain subsets, we see those new opportunities for targeted therapies. And even and it was even mentioned that we have now also menin inhibitors, at least at the edge, and the trials are coming out, meaning that we see concrete improvements for specific subgroups. And of course, I mentioned the cellular therapies and CAR T-cell therapies because they have been like enigmatic in this field, but small molecules such as menin inhibitors, I think, are even more relevant, especially when you're looking at the broader hematology and oncology setting, going even until lung cancer. And after all, this is improving those specific subgroups, but we need to bring those two evolutions together because they have synergy. And if we leverage this synergy from more precise diagnostics and more adaptable therapies to our patients, we can really make a difference. And not only in the diagnostics, but also for the risk prediction, follow-up with MRD, and ideally also with tailored treatment and mobile health applications. Now, how is this happening? When is this happening? Sometime is this something not happening? I will be brief about this part. AML heterogeneity is something known to you, and it has been also introduced also by my previous speakers. This has been discussed widely, so I will be very short of you. You know genetics are important, and ELN is the current standard of classifying these. Going beyond those clinically relevant classifications, there's a myriad of works coming also out of the domains of applications of those new technologies, in particular machine learning technologies, but also new data sources that are being exploited, for example, such as the proteomics or other omics. And I will try to give you a brief summary of what has been done. It's a hand-picked selection of studies, but just to bring you in the scene and to give you this idea. However, these studies that have been coming up over the last decade are also challenging with other issues that come along with them being big data studies, which is an overwhelming amount of data that requires analysis. Within this overwhelming amount of data, also variants of unknown significance. So we know something about the patients, but we don't necessarily know which action to take now next for those patients. So which is the next step? And many of our studies suffer also from the burden of high dimensionality of data, which means that there's the multiple hypothesis limitation. And ultimately, this is one of the consequences for those models. They require great robustness in order to be applicable for us as clinicians, because otherwise they may only work in Warsaw, but not in Bogusz. And this is not what we need. We need something that works universally. Beat AML is one of the large initiatives that brought together a large data set that is also publicly available, so this can be reanalyzed And this is, I think, also one of the very valuable advantages that we are experiencing in the current times, that open science is increasingly available. This brought some insights into drug sensitivity analysis, discovered also certain novel mutational events in AML, and also highlighted to certain susceptibilities and resistance mechanisms in, for instance, TP53 and also WT1. Just one of those insights here. As you can see, this is already resembling the matrix image that I showed at the beginning. So if you're looking at those even in larger tables, then you will have that image. Oops, no, this was not the intention. Now we did I'm not sure, but we are doing fast forward right now. Okay, sorry, that was the talk. I'm not sure if we can get back eventually. Yes. But as said, the Beat AML brought together two sources of data, genomics and transcriptomics data. So we're completing, but there's more to find. And if we move forward here, another perspective on the question of transcriptomics is digging deeper into the single cell universe. And I'm just summarizing evidence that is already out there. And one of those perspectives brought the different stemness sources of the AML leukemic cells, being like hematopoietic stem cell types, or GMP type, or rather mature type or monocyte-like types. And this was also exemplified with the use of transcriptomics again. So the combination again of two different angles and perspectives brought together. This was further developed now in the work from Zheng that has also brought up a new study in this year, and the number of classes expanded further into 7 classes here, from those stem cell-like types to the monocyte-type types and to the dendritic cell-like types, also again based on the single cell data. And the categories were also associated with the changing clonal composition. So this is work that we've seen already for the genomics analysis over time, where we have larger and smaller clones. This is also here confirmed for the single cell data and the drug sensitivity. I thought I could move on, but now it's stopping here. Now it works. Other perspective, proteomics. So the proteogenomic perspective on AML, bringing here multi-omics data together from genomics, proteomics data, and identifying also a new class, the so-called MITO cluster, which is a category with a high expression of mitochondrial proteins as a way to stratify beyond ELN 2017. But please note, of course, there's ELN included, this cluster included, and age in the multivariate analysis, so no further classes regarding to the genetic classification beyond the ELN models. And what those colleagues here now brought together, and this is, I think, just to complete this section, is that when you have an increasing number of genes involved, then you have also in those more complex models decreasing burden of or decreasing impact of the individual genes. Meaning if you have more genes, probably the smaller proportion of those individual genes will have its respective burden. But what the authors here also made very clear is that in order to dissect those increasingly complex data sets that are brought together from the different data sources, you also have to identify those nonlinear correlations within. And this was one of the contributions, coming up with a nonlinear model in order to analyze the association between those genetic markers, and also to associate these with response in treatment. Now, the latest the latest results with new sequencing technology is definitely this nanopore sequencing, which is utilizing and focusing precisely on the epigenomic data, and this was presented at last year's ASH and has just been published as a full paper, which was able, in order to categorize leukemia leukemic patients, based on their epigenetic profiles with a quite rapid sequencing approach. It's quite interesting because the DNA methylation profiles were focused on, and it's an approach that is pan-leukemic in a certain sense, not only focusing on AML, which we are here in this session more interested in, but also ALL. And this is what they call the ALMA, so a methylation atlas of leukemia. What you will see here is also interesting, that within those sites of the methylations, the dimensionality reduction that the authors applied was to 5 dimensions. So it's, even though they illustrated it here in 2 dimensions, the categorization remains in an unseen space, so a space that you will not be able to dissect with a human eye. Now, is this the future? And here I summarize this once again, and I think this is being streamed, so maybe you can review those once again also after the session. You can either bring together one set of data, add different other perspectives, single-cell data, and also the functional drug screenings. This is one perspective, so the kind of data types. And the other perspective is, of course, the cohort size. So how many patients, how representative is that insight that you can have on the advent of your own patients. I think when the question was, is there room for AI? For sure. So we've seen already from those data sets how they benefited in their analysis. But as I said, what kind of AI is rather the question. And it needs to be matching to the respective questions that we want to ask as physicians in order to be meaningful. And I thought I could move forward. So here we have it. When we want, for example, to address AML genetics, something that we within the Harmony Foundation worked particularly on, we were set with the question, do we want to have a more visual method? Do we want to have a certain set of variables included? And here it was categorical variables. Do we want to have a strongly generalizable model? And indeed, this is the case. Those were motivations that brought us back to an old friend, which is the Dirichlet mixture model. We see here also the impact of the large cohort size, which we think was very important to make it even more robust. Why do I say an old friend? Because a similar approach was already previously used. It has been pioneered by our colleagues around Papamenui and Döner some 10 years ago already. And how was this methodology reused? I'm coming to that again here. It starts from, well, let's start here again. It starts actually from the matrix. Now here we come to the matrix, which was in the title of my talk. However, this matrix is looking quite familiar to you because it's tabular data after all. So it doesn't need to look that complex when you look at the matrix. We have mutational data for a long set of patients and for a long set of mutations. Inserting these as binary data, this is a matrix. This data was pre-processed, inserted into a hierarchical Dirichlet mixture model, which has the art to determine, to self-determine the number of components that are least overlapping and as small as possible. So this is the idea. Not, did I say as small as possible? I apologize. As large as possible, but at least as overlapping. Because of course, when you want to fill in a room, you can always fill it with very small bubbles. But when you want to fill it with large bubbles, you will always have some overlap between the circles. You try to make them as large as possible, but as least overlapping as possible. And then we added, in addition, our innovation as a post-processing of those strategies, a purely statistical assignment of the patients to the clusters after all. Basically, you have components here with a different composition. Some of these are NPM1 dominated, some of these are TP53 dominated, but they are also heterogeneous. So you may have also TP53 represented in one component. It's part of the problems if you're looking into the complexity of data with smaller chunks that you will have overlap within certain genomic dimensions. And this is something that I think we also need to learn to live with. However, as I said, we have sometimes components with unknown significance. Our task then at the second step is to make sense out of these components as we find them. Now, what does that mean technically? As I mentioned, this was a large and diverse data set coming out across Europe with 5,000 patients typed for 55 genes, as well as also cytogenetic categories. So we had a very large set of genes here involved, intensively treated patients, and we got a lot of information about their genetic composition. This is the baseline characteristic. As you can see here, the ELN risk groups were equally distributed across those sets of data. Coming to the core of the results, and this was data that we presented this year's at least at this year's EHA meeting in the summer, we identified using this methodology with an unsupervised manner. So we did not, cherry pick the most interesting genes. This was done by categorical algorithm work. We identified genes and categories that are relevant also to our current understanding, such as, for example, those with CBP biallelic mutations. We spoke today already about the NPM1s and their combinations. We found also and could confirm those groups with FLT3 and NPM1 co-presence. We also identified a group with NPM1 and other passenger mutations, and also those with NPM1 and IDH2 mutations. Importantly, we identified also new classes. For example, here for the myelodysplasia-related gene mutations, there were 3 classes instead of the 2 previously described classes. We also confirmed that the one with DEL20Q. We were able to split also classes here for inversion 16 between those that had a co-mutation of inversion 16 and FLT3 and another larger class of inversion 16 mutated ones. I will give you more details about that specific group. What you could see in that data set is that the outcomes differed significantly between those 2 classes when patients were treated intensively. And in addition, they had also a slightly different mutational profile. And as you can see here, the co-mutational pattern was quite different. In particular, this subset here that was co-present with more frequently FLT3 mutation was the one that had the worst outcome. And this was also corroborated by the multivariate analysis, where only those with inversion 16, but not those with inversion 16 and FLT3 co-mutation, had the improved outcome when counting in also the ELN risk groups, transplantation, and also age as demographics. So, and of course, all of the other categories that we identified, so those 17 categories. There were also some other groups that associated with significant differences in overall survival, and I will show you the results from the multivariate analysis in another table once again. We were able to utilize a public data set from precisely the NCRI study cohorts, if they want us to show those data. Perfect. And what was interesting to see that we had a very robust model that for the assignment of the phenotypes and genotypes had a strong overlap. Here we show it for the age distribution, but also for the blast counts of the 2 cohorts, as well also for other laboratory counts such as platelets and hemoglobin. They were really overlapping. I'm unhappy because we don't see actually the 2 curves very well, but I think this is reason because they're very strongly overlapping here, and the image is slightly overlighted. We had small differences within the proportion of the clusters, which were below 5% for those 2 clusters and remained below 2% for the other clusters as well. So it's a very even and reproducible model, and probably even more important to you, we were also able to reproduce the outcome association here on that cohort. Our suggestion here for a renewal of the ELN classification is to add patients with more favorable outcomes than the ones that have been assigned by the classification itself, and to compare those very adverse ones in the other side that have worse associations with outcomes than the ones that were also adverse risk, so even as very adverse patients. I do not think that I have much time left, but I will try to conclude on a few points that are probably also relevant to your practice or to the questions asked here in that context. We may use AI also beyond the classification process, although this is the focus, of course, of our meeting today. Meaning, for example, we can utilize also AI-based tools against health disparities. And one of these is probably access to diagnosis, access to treatment. Here, this is also a collaboration that we're having with Marta. It's regarding to an AI tool that is utilizing only laboratory data in order to categorize patients between the acute leukemia and in particular for the acute promyelocytic leukemia subtype in order to allow rapid referral to reference centers. Other possibilities, and I'm sure you've heard about these, are utilizing AI, of course, in marrow diagnostics. Those works are already a bit older, but still very relevant. Now, is AI all we need? And I will be very, very brief on this. No, of course, because you need resources in terms of data integration. But I mentioned already that data integration is something happening right now. And the FHIR standard for the hospital data systems has been adopted across Europe, but also in the United States. But just if you want to apply things in your own hospitals, think about this. AI is the tip of the iceberg. You need data, you need a platform, and you need then to implement that in your structure. But this can be possible. This is possible, it can be done. And if I'm allowed to move forward, I'm also coming to the end. Sorry, because so far there's still, it's just not. Because so far there's still space for AI trials. I wanted to show that we are lacking behind our radiology colleagues, but probably there's something you know. But implementation of trials is something that can happen quite rapidly. This was shown here by our Chinese colleagues who implemented DeepSeek rapidly. As I said, this is not science fiction, this is all real, and I'm just showing you what is already existing. So those are publications, it's probably still experimental, but those can be translated into practice. Mobile devices, apps for referrers, AI support to the tumor board, genetic refined classification for acute leukemia, personalized blood transfusions, also important, clinical decision support systems for clinical complications, and also wearable surveillance for outpatients. There are classifications also for complications after transplantation, such as graft versus host disease, and of course also implementations for EPROs. I hope that this is encouraging to you, and now I want just to close that presentation and thank everybody for your sustained interest and listening to us. So continuously improving stratification is something we've seen. Our methodological innovation was the unsupervised learning. We added a more holistic understanding, subdivided previously clusters, and also refined the outcome prediction and had a diverse cohort. Thank you so much for your time. And sorry for being over.
We just have time for one short question, or if you prefer, we can do the discussion during the coffee break, because we've got this short delay. So I invite you to have a short break, coffee break, and then we can discuss all 3 lectures during the break. Okay?
Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku, nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie. Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku, nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie. Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku. Nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie. Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku, nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie. Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku, nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie.
Okay, I hope that you are still able to listen and other topics, but they are really, really interesting. So we move now to chronic myeloid leukemia, and I want to introduce Professor Sacha from Krakow to give our first lecture about chronic myelocytic leukemia, Mission Possible. Yes. Then we will speak about the blastic phase of CML with Professor Góra Tybor from Łódź. We are expecting Dr. Hart, our cardiologist, but he's on a traffic jam. Hopefully he will arrive soon. So maybe we can switch, Laura, your lecture first and then the Hart lecture, okay? We will see. So, Professor Sacha, please.
Dear organizer, first of all, thank you very much for inviting me to your secret garden of leukemia. And Marta has asked me to, to discuss with you the Mission Possible. Of course, this drives us to a famous movie with Tom Cruise, but I remember another movie, Blues Brothers. I've got a mission from God. So I will try to make this mission possible. And let's start with chronic myeloid leukemia. Impossible, unfortunately. Okay, let's try this. Yes. So this is the first survival curve drawn in 1924. As you could see, in 52 patients who were not treated with anything. And if you look at the next curve, which is drawn by our Italian colleagues in the 70s of 20th century, the advantage of overall survival, mean survival, is about 1 and 1.5 years. So in comparison with no treatment, this advantage is very small. So in that time, the goal of therapy was just to achieve hematologic response. just to have the normal CBC, spleen size reduction, improvement of quality of life, and to live better, not necessarily longer. Of course, the change came with the 1960 when Peter C. Noel and David Hungerford detected small 22 chromosome. And it took about 13 years for Janet Rowley, who, using the banding technique, just proved that this is not the deletion, this is reciprocal translocation between the chromosome 9 and 22. And then came the detection of the chimeric gene BCR-ABL. And then the story of successful treatment starts from this time on. Okay, but in that time, some kind of innovative treatment was interferon alpha. And the goal of therapy was to achieve at least major cytogenetic response, which meant to have not more than 35% of Philadelphia positive metaphases in classical cytogenetic analysis. But this goal was achieved only by 20% of patients. Of course, the CCYR was even better, but this goal was achievable in 5% of patients only. And then we have the big step forward thanks to the Kary Mullis, who went to Yellowstone Park, and he asked himself how to make it possible what is done in the nature, that the two cells, one cell which is dividing, receives the same genetic material. How to resemble this in the artificial conditions. And looking at this very hot springs, he realized that there is a life there, and there is a bacteria, at least one, which is living, which can survive. And then he isolated the first polymerase from those bacteria, and this bacteria was termed Thermus aquaticus, and therefore the first polymerase ever used in the PCR method was Taq polymerase from this bacteria. So then we received these wonderful devices which can make the gene visible, and we can detect BCR-ABL gene thanks to that. Of course, the next step was the quantification of this method with the quantitative PCR, which shows just the quantity of the transcript of the gene. Then we got the very fast gene expert, which can give us the result in almost 2 hours. And they are reliable, they are good, and they are sometimes used even in our laboratory. And then we have the digital PCR, which makes this analysis even more repeatable, more accurate, and it detects just the absolute number of DNA copies. It does not have to have the standard curve. So there are some different platforms that are used currently for digital PCR. And then Brian Drucker invented the CpG 57148. Then it was renamed to STI 571. So that was imatinib. Imatinib, the first inhibitor of tyrosine kinase, who is blocking the place for ATP. And we know the whole story that in the 90s, the chronic myeloid leukemia was one of the first indications for allogeneic bone marrow transplantation. And in year 2000, it stopped and collapsed. So then the Alois Gradfol named this drug as stop transplantation immediately, because thanks to the introduction of this drug, the number of allogeneic bone marrow transplantation dropped rapidly. So now we need this method for about 2% of our patients with CML. So the first inhibitor was imatinib. Imatinib works very well. You could have a 10-year survival at the level of 91, 92%. And therefore, this is the inhibition of the BCR-ABL is called as the Mozart of antineoplastic medical therapy. And thanks to the TKIs, the life expectancy of our patients are reaching just the life expectancy of normal, lifelong of normal population. Okay, but if you take a look at the population of patients who are treated for more than 10 years, we can observe, as in this analysis we did in our department, that the curves of overall progression-free and event-free survival are dropping down beyond the year 10, which means that majority of patients need to be treated with the second, third generation of TKIs. Partially due to ABL kinase mutations, they are just developing throughout the treatment, during the treatment. And then the second or third generation TKI should be applied. But there is no consensus regarding the usage of second generation TKIs up front. We think that they don't have any advantage in terms of overall survival over the imatinib when using the first line. However, if TFR, so treatment-free remission, is the goal of the therapy, then the second or third generation TKI are superior. However, the third generation TKIs, meaning ponatinib, is usually used in patients who does not respond to first and second line. So probably the TFR is very difficult to obtain. But we know in the same time that vascular toxicity is the main limiting factor for this therapy. So the goals of the treatment of CML are evolving. And as I mentioned, that was first the quality of life. Then we aimed to achieve the complete cytogenetic response, then the MMR, then deep molecular response. And starting from 2020, when the last ELN recommendation were published, one of the goals of the treatment is just treatment-free remission. So live long and possibly without any therapy. So this is Philippe Rousselot, and he was that brave just to stop the treatment in first 12 patients in 2006, and he published this in 2007. He stopped the treatment with imatinib in 12 patients who achieved the negativity regarding the BCR-ABL, and that was successful. And he was followed by François Xavier Mahon, who published the 100 patients who stopped successfully this therapy. And now this is some of the strategy we consider when seeing our patients. However, in the last ELN guidelines, we find a sentence that if you have this idea to increase the likelihood of achieving the treatment-free remission, and therefore you are switching the therapy from imatinib to second generation TKI, for example, you have to consider that in some patients, particularly in elderly patients with comorbidities, this could be not a good idea. So you have to really consider the comorbidities of the patients and the benefits the patient could derive from this strategy. This was supported by the wonderful work by Fabio Efficace, who showed us that probably those patients who benefit the most from cessation of the treatment are those who are younger than 60 years old. Because if you look at the fatigue, this is very commonly appearing the side effect of TKIs. So we suspect and we expect that if you start the treatment, the fatigue will be reduced. But if you could see, this is true for patients younger than 60 years old. The same is for cognitive functioning. You could expect that stopping those treatment could increase the cognitive functioning. But again, this is true for patients younger than 60 years old. So probably this strategy applied to younger patients. And another point was raised by our German colleagues, because we believe that early response and the dynamic of early response is very important, and we try to switch the treatment if the patient was not reaching the optimal milestones. And they published a paper where they proved that it doesn't really matter if you have the reduction for less than 10% or less than 1% at 3 months and 6 months. As you could see, the overall survival curve, they are going together. They spread at 12 months, for sure at 24 months. So probably less than 10% at 12 months and less than 1% at 24. Those will be the optimal points just to switch the therapies. So that was the long discussion before the ELN recommendation were published, and now we have them from the April this year. And if you look at the categories, we can see that there is a definition of favorable response when the treatment switch is not necessary, warning conditions, but when the switch may become necessary, and unfavorable response when the treatment switch is preferred. So those categories are somehow weakened than in previous ELN recommendations. The time points are the same, the values here are the same, but the meaning is different. So it came back, the idea of having patients like late responders. We observed late responders during the time we had only imatinib in our armamentarium. So they were patients, they started to respond after 6 months, after 1 year, after 2 years. But there was nothing else, so we just maintained the therapy. Then it came the era of second and third generation TKIs, and it switched the therapy. But now this is underlined that probably there is some group of patients could be called late responders. They may not require a change of therapy. Okay. And last but not least, we have a new player in the game. This is the asciminib, which is the myristoyl pocket inhibitor. So it acts in totally different place in KD molecule. And we have next generation sequencing. And I attached this slide to this story of asciminib, and I will show you why in a minute. So we could see that there are some additional mutations in so-called non-cancerous genes. We can detect those genes since many years in some part of patients with CML, even during the diagnosis. But now we do think that we know more about the clinical impact of those mutations. So the most commonly detected is ASXL1. As you can see, is detected in 7 to 9% of patients in chronic phase at the diagnosis. And this is the meaning. So it means that in those patients who are treated with asciminib as a first-line treatment, you could expect that almost 1/3 of them will develop another mutation in the kinase domain. And in another group of patients, it was proved that presence of ASXL1 could diminish, can reduce the rate of MMR and reduce the event-free survival. So that's the meaning of ASXL1. And fortunately, we are observing the fascination study, which is testing the efficacy and the tolerability of combinations. Combination of asciminib with different kind of TKIs. And in this study, it appeared that if you have ASXL1 mutation, you do better. But you have to be treated with combination with imatinib plus asciminib or asciminib plus nilotinib or dasatinib. And the same thing is for deep molecular response. If you have ASXL1 mutation, you have the better rate of deep molecular response than patients do not have ASXL1 mutation. Unfortunately, during this treatment, there are some additional mutations. They appear in the myristoyl pocket. You have them listed here. And with this, we have another story. which tells us about some confirmation about the BCR-ABL and action of asciminib. Just to explain, just to have the BCR-ABL protein totally inhibited, you have to have a close contact between SH3 domain and kinase domain. And the ABL exon 2 encodes almost half of SH3 domain. So if the transcript of a patient is lacking this exon 2, like here in those called untypical transcript, you don't have this, this SH3 domain, and there is impossible to have them in a close contact with KD mutation. And it results with resistance. So all patients who were detected with atypical BCR-ABL transcript, they were resistant to asciminib. So we are in this way, we are ending up with about 10% of population of people, they will not benefit from asciminib treatment. So these include the elderly people with some cardiovascular problems because asciminib could induce hypertension. And then we have 7 to 9% of patients who are detected with ASXL1. Of course, you can overcome this problem treating this patient in combination, and the rare patients having an atypical transcript, which accounts for 1, maximally 2% of patients. So just to conclude, I think that at the moment there are diverse goals of therapy. For example, age could be the driver of some discussion with patient, what is the goal of the therapy. And this therapy is more and more tailored. And this is guided by ABLKD mutation, by NGS, which is not recommended as a routine care procedure. Not now, but I suspect that in the near future it will be. And by the comorbidities. And of course, quality of life becomes more and more important in the decision making, how to treat our patients. So at the first glance, this looks like a very easy procedure, but we can be aware that we have to rehearse a lot. Thank you very much.
So now we move to plastic face.
I would like to thank the organizer for inviting me for this conference. Again, I have problems. These are my disclosures and the plan of my presentation. The first point is problem with definition of accelerated and blast phase of CML. It is not a new problem because there is still no consensus among experts regarding the definition of these advanced phases of CML. There are 3 commonly used consensus guidelines: MD Anderson guideline, ELN, and WHO criteria. Historically, all 3 of these groups divided advanced phases of CML into either accelerated or blast phase. But the recent recommendation of WHO eliminated accelerated phase of CML completely. So they stated that AP is omitted in favor of an emphasis on high-risk features associated with chronic phase progression and resistance to TKI. This table shows a different definition of blast phase and accelerated phase, and the threshold of blasts, which allows us to recognize blast phase, is 30% for ELN and MD Anderson, and 20% for WHO and ICC classification. And I would like to underline that the definition of lymphoblastic blast phase is different, and just the presence of increased lymphoblast in peripheral blood or bone marrow is enough for WHO, and more than 5% of lymphoblast according to ICC. And moving to accelerated phase, it disappeared, as I mentioned, from this newest recommendation of WHO, and it still exists in ELN and MD Anderson and ICC classification, different threshold of blasts, the additional features characterized for accelerated phase, lower platelets, higher count, basophil counts, splenomegaly, and additional chromosomal aberration. So these are the new ELN recommendation, and the slides is from a presentation of Professor Jane Apperly during the last IHA meeting. The decision to eliminate the accelerated phase remained controversial, and the ELN experts failed to reach the consensus. There are arguments for this decision. The first one, genetic studies suggest that CML is a biphasic disease, and also patients presenting in accelerated phase are treated very often with TKI monotherapy, and most respond as chronic phase. And against this decision, that accelerated phase is long-standing and well-understood definition, and accelerated phase helps identify patients who may benefit from more potent TKI as first-line therapy. Also, if we remove the acceleration phase, it would be difficult to compare the old studies with the new ones. What is the mechanism involved in CML progression? It's very complex and not well understood. In the center is the overactivity of BCR-ABL kinase, which leads to genomic instability, mainly through the increased production of reactive oxygen species. And this genomic instability leads to many genetic and epigenetic aberration, which promote anti-apoptotic and proliferative pathways. Patients with accelerated and blast phase have more mutated cancer genes than patients in chronic phase, and some of them are more typical for lymphoid blast phase, others for myeloid, some for both, like RANKS or mutation of ABL kinase domain. This very important goal of our activity to identify patients who are at high risk of transformation. Blast phase CML is a very rare diagnosis. In the blast crisis, we diagnose only 2 to 3% of patients. A further few percent of CML patients progress from the chronic phase to more advanced stages of the disease during treatment, during TKI treatment. So identifying patients who are at high risk of transformation remains a challenge. Of course, the incidence of blast crisis depends on treatment, and here you can see the huge difference between this frequency before era of TKIs and now. Unfortunately, even upfront therapy with more potent second-generation TKIs doesn't completely remove the risk of progression. And looking at this table, in IRIS trial, after 10 years of follow-up, 7% of patients progressed. In German CML4 study, 6% of patients on imatinib. In NSND study, 8.5% of patients in imatinib group and 4% in nilotinib group. and in decision comparing imatinib to dasatinib, 7 and 5% respectively, before imatinib versus bosutinib, 3 and 2%. In new WHO definition, the high-risk CML replaced the old accelerated phase. And the expert indicated the high-risk factors at diagnosis, like high ELTS score, a higher number of blasts, basophils, additional cytogenetic aberration, especially with chromosome 3, monosomy of 7, isochromosome 17, and of course complex karyotype. Also clusters of small megakaryocytes with fibrosis in the bone marrow. And on treatment, no hematologic remission on first-line TKI, resistance to second-generation TKI, development of new genetic aberration, and presence of compound mutation. The other factors like poor drug adherence or problems with drug absorption, drug-to-drug interaction, or drug interruption because of toxicity, for example, cytopenias. What can we do to prevent transformation? Is the good idea starting therapy with a second-generation inhibitor? As Tomek Saha said, there is no convincing overall survival benefit in most studies, but the treatment with a second-generation TKI resulted in a lower number of transformation. Here we have the results of NSND study, 10 years follow-up, and especially in patients in intermediate and high SOCAL risk group, there is a difference in the percentage of transformation. For example, in intermediate group, patients treated with imatinib, in 10 patients, the transformation was observed, only 1 and 2 in nilotinib group. So what else can we do? Of course, very important is to assess response at appropriate time points and change therapy if response is not favorable. We have a very detailed indication in ELN recommendation, and of course we should follow them. The last but not least point is that we should think about transplantation early enough. These are recommendations regarding which patients should be considered for allogeneic stem cell transplantation, and of course all these genetic changes, chromosomal aberration, also failure to achieve any cytogenetic or molecular response on second generation TKI after a minimum of 3 months of therapy. Also toxicity, hematological like cytopenias or not non-hematological, preventing consistent TKI dose intensity resulting in early molecular response failure. Also compound mutation and presence of lymphoblasts at diagnosis. So moving to treatment, first accelerated phase and blast phase. We have 2 different situations. De novo accelerated phase have the better prognosis, and the patients with de novo accelerated phase are often treated with TKI monotherapy with success. Much worse prognosis is for patients who progress to accelerated phase while on TKI therapy. And here you can look at the results of a PACE trial for patients with acceleration. Only about 30% of these patients achieved cytogenetic response, and the PFS at 5 years was 22%. Overall survival at 5 years, 49%. So these results are far from optimal. This proposed treatment algorithm for patients with accelerated phase, so de novo, we prefer second generation TKI, and if optimal molecular response is achieved, we can continue. But if it's suboptimal, we should switch to the stronger inhibitor, for example, ponatinib, and consider transplantation. And in case of transformed accelerated phase, we prefer ponatinib, and from the beginning we consider transplantation, especially in other high-risk features. And moving to the blast phase, the outcomes of patients with blast phase are particularly poor, with median survival generally less than 12 months. Several factors may influence the prognosis, like de novo or transformed blast crisis, the presence of high-risk chromosomal aberration, this 3-7 complex karyotype, also phenotype. Lymphoblastic crisis generally has a superior outcome. The primary goal of the therapy in blast phase is to return to chronic phase CML and proceed to an allogeneic transplant if patients are eligible. Given the aggressive nature of blast phase, TKI monotherapy is insufficient, and more intensive combination strategies are recommended for most patients. In this table, we have the results of prospective studies of TKI monotherapy for patients with blast crisis. Yes, you can see that survival is just a few months, so it's not satisfactory. And in this table, we have results of combining treatment, chemotherapy plus TKI, and this chemotherapy similar to induction of acute myeloid leukemia, so intensive chemotherapy, or combining TKIs with hypomethylating agents. It should be underlined that results are similar, are better than for monotherapy, but still not very good, and median survival is about 12 months. This one study, the survival is 27 months, but it's only 7 patients. Combined therapy of azacitidine with different TKIs, and these good results, unfortunately, was not confirmed in other studies. There are several currently active studies, mainly combining hypomethylating agents with TKI inhibitors and venetoclax. We are waiting for results. And moving to lymphoblastic blast crisis, the prognosis is better, and the chemotherapy is the same as in acute lymphoblastic leukemia, Philadelphia positive. So it's usually hyper-CVAD combined with TKI inhibitor. We can also go for antibodies like biphasic blinatumomab or antibody drug conjugate like inotuzumab. And talking about the progress in the treatment of lymphoblastic blast crisis, it's impossible not to mention the CAR-T therapy. There is an example of 16-year-old male presented with lymphoid blast crisis at diagnosis. He received a huge number of different therapies, 2 transplants from 2 different donors, antibodies, In the end, he achieved remission on combining therapy with ponatinib plus asciminib, and he received CAR-T therapy. After 2 months after this therapy, he still was in complete hematological remission and molecular remission. What about the prognosis after transplantation? Of course, it depends on the stage of the disease, and it's better for accelerated phase and second chronic phase as compared to active blast phase. Other adverse prognostic factors include a high EBMT score, reduced performance status, low CD34 plus cell in the graft, and higher donor age. This table summarized analysis of outcomes for patients with blast phase after allogeneic transplantation, and as you can see, 3-year overall survival is about 30–40%, with relapse incidence 40 to 50%, and about 25% non-relapse mortality. So the proposed treatment algorithm for patients with CML blast phase depends on immunophenotype. Both are based on combination of chemotherapy with a TKI. We prefer ponatinib. In myeloid blast phases, we combine ponatinib or other TKI with AML-like induction, intensive chemotherapy, or hypomethylating agents plus venetoclax. And transplantation is recommended for all eligible patients. And in case of lymphoid immunophenotype, again, ponatinib is preferred, and we use ALL-like induction. We can combine this with blinatumomab and/or inotuzumab, maybe in the future with CAR-T cell therapy, and transplantation is also recommended for nearly all patients. So my take-home message are, despite the dramatic improvements in outcomes for the majority of CML patients, treatment of more advanced stages of the disease remains unmet clinical need. In particular, the prognosis of patients with blast crisis remains very poor. The outcomes of patients with accelerated phase are more heterogeneous, and some patients may have relatively good outcomes with TKI monotherapy. A major focus needs to be prevention of progression to blast phase CML with early intervention for those patients failing to achieve milestone responses. Due to the rarity of blast phase CML, clinical trial data are limited and guidelines are often based on expert opinion. But given the aggressive nature of blast crisis, TKI monotherapy is insufficient, and more intensive combination strategies are recommended for most patients. The primary goal of therapy is to return to chronic phase CML and proceed to an allogeneic transplant if patients are eligible. Thank you very much.
Thank you very much. So now we move to cardiological topics. As you know, our CML patients has a lot of cardiological problems, so this is why I asked Sebastian Schmidt to tell us about this a little. So please, stage is yours.
Good afternoon, ladies and gentlemen. Great honor to be invited to this awesome Congress. Congratulations for amazing program, and I'm very happy to be included. And I thank you for the opportunity to speak in the very nice city, Bydgoszcz. This is my next time. And thank you for very provocative title of my lecture. So the general topic of this meeting is amazing. The secret garden of leukemia. So Thank you once again. So my story for CML patients began more than 10 years ago when I met some patients with severe, really severe pulmonary hypertension related to dasatinib. So a colleague from the US invited me to speak about, to present my first experience during the first Global Cardio-Oncology Summit in Nashville. So that was amazing step in my CV, because after that Congress I was invited to all Congress under the name of Global Cardio-Oncology Summit. So yes, my Polish story began 1 year later, together with Tomek Sacha and Professor Tibor Góras. I'm so sorry. We wrote the special document about the selections, recommendation about selections, special selections of patients for treatment due to CML based on the cardiovascular reason, cardiovascular history. And I'm so sorry. Of course, the next step in my CV was this development, the development of these guidelines together with my friends from Europe, Alexander Lyon and Teresa Lopez Fernandez, current and past and current chairs of the Council of Cardio-Oncology in the European Society of Cardiology, Council of Cardio-Oncology in the European Society of Cardiology. So we started the new era for European cardiologists because we started the discussion about cardiovascular diseases in patients with different cancer diseases, including hematological malignancy, and included CML patients, of course. And if you read this document, if you can still read this document, and I suggest to read, because you can find the special algorithm for CML patients, and you can read the okay, I can see the pictures, but as you can see, nilotinib may lead to hyperleukemia, hyperlipidemia, and typical cardiovascular symptoms related to atherosclerosis development. So we can observe acute cardiac events, acute ischemic cardiac event, and of course stroke and acute occlusive arterial disease in legs. But dasatinib is different because rather provoke pleural effusion, pericardial effusion, and heart failure, and very important, dasatinib may induce the increase of pressure in pulmonary vessels. So I observe some patients with severe pulmonary hypertension. And last drug, ponatinib, the special one among these selected TKI drugs, because ponatinib may lead to the same complication like nilotinib and like dasatinib. So ponatinib may include all possible cardiovascular complications typical for this group of drugs. And our recommendation how to monitor, how to improve the quality of life and prognosis of our patients with CML regarding cardiovascular status. Of course, we should control all risk factors related to atherosclerosis. So we should control blood pressure, ECG, lipid profile, and of course, glucose metabolism. This is very important, and at that time, it was only level C of recommendation, so it means only expert opinion. So we need more data, how in this way we can improve the prognosis of our patients. And other problem is the risk of heart failure and development of especially pulmonary hypertension. So it's not surprised that we recommend to perform echocardiography before treatment with dasatinib. This is very important, and we recommend this as, once again, C level of recommendation, so experts' opinion. But as you can see, it's not necessary to repeat echocardiography during treatment. Of course, we should use echocardiography when we observe new symptoms, dyspnea, edemias, etc. But it's not necessary to repeat the echocardiography in asymptomatic patients, but sometimes in high risk of patients with severe, very significant history of cardiovascular diseases, we should consider 2I is recommendation. With me understanding, we should consider to use echocardiography to control, to evaluation, for evaluation of our patients. And once again, this is only expert opinion. Some data why we wrote such recommendations, such guidelines for CML patients. As you can see, this drug may lead to development of heart failure. It may be surprised, but as you can see, imatinib may provoke heart failure, and this development of heart failure is dependent of the age of patients. Geriatric populations may be understood at the risk as in the general cardiology. It's not surprise. But other problem is related to bosutinib, because data associated with bosutinib confirmed that patients during the next line of treatment, second, third, and etc., may be at significantly higher risk of development of heart failure. This is a very practical point for discussion and for planning of sequential therapy due to CML. And the next point about dasatinib, as I said previously, dasatinib may provoke pleural effusion or other typical symptoms observed in heart failure patients. So look at the data, very first publication about dasatinib and the importance of impact of pleural effusion for the survival and prognosis. And this study concluded that pleural effusion was the predictor of the development of pulmonary hypertension. So very important for my daily practice, because mainly patients with cardiac history, with hypertension, especially with cardiac history, were at significant risk of development of pleural effusion and later development of heart failure or pulmonary hypertension. So very practical study at the beginning. The next study came from France, very important, because our friends published the data about only nine patients, but with very severe pulmonary arterial hypertension, and proposed the discussion about the clinical pictures of this disease, of this complication. Like in general cardiology, they observe pulmonary arterial hypertension mainly in female, only one male. And very typical situation, pleural effusion was the first symptom, and later development of pulmonary arterial hypertension, and sometimes there was a coexisting symptom related to pericardial effusion. As you can see, when authors discuss the problem, if these symptoms, this disease, cardiac disease is time-related problem, they conclude that rather it is late complication. So it's necessary, that longer time is necessary to development of the significant changes in the blood vessel, especially in pulmonary vessels, and everything is associated with molecular pathways, because dasatinib may block the molecular pathways related to SAR kinases activity. So in this way, induce the significant changes in the pulmonary vessels, and as clinical consequences, we can observe the increase of pressure in pulmonary vessel, and we can observe the symptoms related to pulmonary arterial hypertension. This is very interesting because before the dasatinib, we use imatinib, and imatinib is completely different because we tried to use imatinib for patients in cardiology, for patients with idiopathic pulmonary hypertension, pulmonary arterial hypertension, and here, as you can see, we observe the decreasing pressure in pulmonary vessel. So sometimes we still use imatinib for patients with very severe pulmonary arterial hypertension before lung transplantation as the way to heart and lung transplant, but the problem is with the risk of bleeding. We observe many episodes associated with severe bleedings. So this is only one reason why this drug, imatinib, was not adopted as the classical drug for treatment of pulmonary arterial hypertension in general cardiology. And the second study came from US, very important because large population was analyzed, 41 cases with pulmonary arterial hypertension with diagnosis confirmed by right heart catheterization, confirmed by invasive cardiologists. It's very important because in this way we are sure the diagnosis is correct and we should use the typical targeted therapy for pulmonary arterial hypertension. As you can see, we can improve the prognosis of such patients, and many of them experience complete resolution, so normalization of pressure in pulmonary vessels. But our colleagues from France showed us that not all patients may experience the normalization of this complication of pressure in pulmonary vessels. Maybe it depends on the activity of targeted therapy because France colleagues prefer to use bosentan. This is other drugs. We prefer as you know, maybe we prefer to use sildenafil. Viagra is the original name. But it's the academic discussion. Maybe there is other explanation of the no complete resolution of this event because pulmonary hypertension is multifaceted disease. So we have patients with typical group 1 and drug-induced pulmonary hypertension is typical example of this disease, and we can use the targeted therapy, for example, sildenafil with good outcomes. But other problem are the patients with hematological disorders when the baseline disease may provoke the significant changes in pulmonary vessels. So, you know, some hematological disorders may lead to development of pulmonary hypertension, and targeted therapy is not so effective because you may observe we rather observe the changes which are not good for control due to pharmacological action. So this is the real explanation why we can use targeted therapy and why we don't observe the beneficial outcomes. And the next problem, accelerated atherosclerosis related to especially ponatinib and nilotinib, very important topic. we can discuss about the reason related to based on the molecular activities on this drug, but very important is that patients with history of vascular diseases should be understood at risk, and as you can see, rather patients with history of vascular diseases may experience severe occlusion in different sites of arteries. And nilotinib may provoke such event in patients, rather older patients with classical risk factors for atherosclerosis. And very important, how to use the drugs for control, for example, hyperlipidemia, hyperglycemia, obesity. We have new drugs, so this slide is not correct for our daily practice now. And the next very important points, the side effects, cardiovascular side effects related to ponatinib is the effect related to the dose of ponatinib. So when we use the lower dose, we can observe the significantly lower risk of vascular complications. So if we have a patient with severe, significant history of vascular disease, we should prefer a rather lower dose of ponatinib. And in this way, we can improve the prognosis, the outcome of our patients. As you can see, of course, ponatinib was related to the significant cardiovascular disorders, arterial events, especially in patients with history of vascular disease, with history of typical risk factors for atherosclerosis, but with use modern cardiological interventions, pharmacological and non-pharmacological, invasive cardiologist interventions, we can improve the outcome of our patients. So the overall survival may be the same between patients with cardiovascular events and patients without such events. Very important point from cardio-oncological view. And few slides for conclusions. Firstly, we can discuss that patients with atherosclerosis or severe risk factors associated with atherosclerosis are not good candidates for treatment with nilotinib and ponatinib. But patients with diseases related to pulmonary hypertension development or heart failure, but especially pulmonary hypertension, are not good candidates for treatment with dasatinib. This is very logical. The next question you ask me usually how to recognize the risk associated with arterial events and venous thromboembolic disorders. I may conclude very quickly and easy that rather TKIs used for CML treatment provoked arterial events. Of course, we observe higher frequency of venous thromboembolic disease, but the reason the relationship is not statistically significant. Other question will ask me usually about arrhythmias and prolongation of QT. The problem may be observed, but as you can see, this is marginal problem, rather observed in patients treated with nilotinib and sometimes with dasatinib, but the risk of sudden cardiac death is rather very, very low. Of course, we observe some cases of sudden death in patients treated with nilotinib, but usually if we discuss about arrhythmias, we should remember about the risk of atrial fibrillation, especially when we use ponatinib. And next problem, arterial hypertension. Arterial hypertension, not pulmonary arterial hypertension, two different diseases. Arterial hypertension is observed rather only in patients treated with ponatinib, because this disorder, this effect is related to the inhibition of VEGF receptor and PDGF receptor, and this is the molecular explanation of the development of arterial hypertension. Similarly, like in general oncology, when we use anti-angiogenic therapy, for example, due to renal cell carcinoma or other ovarian cancer, for example. And my last conclusion, the problem is real, and the problem is discussed by many experts in the world. And the last publication from JACC Cardio-Oncology, very prominent journal dedicated for the world of cardio-oncology. And we conclude that we need more data about new drugs, especially asciminib. And of course, we will implement newer and newer drugs, and we need more and more data. Now we know that dasatinib and nilotinib and ponatinib should be understood as the additional risk factors for the development of disorders related to atherosclerosis or pulmonary hypertension, or of course heart failure. So I think that we will meet and we will discuss about thrombosis, arterial especially, and I would like to invite you to observe the activity of European Society of Cardiology, especially Council of Cardio-Oncology, where I work. Thank you very much. And what time is? Okay, thank you. Good time. Thank you.
Thank you very much. And now we move to the last but not the least lecture, Laura Lee from London, from Claire Harrison team, but originally from Canada, who will tell us a little about MPN and CML. Yes, please, Laura.
So hello everyone, thank you for inviting me today. So my name is Laura Lee, and I'm a clinical fellow in the MPN team at Guy's Hospital, and I'm from Quebec in Canada. So I'm very happy today to present about the rare but increasing scenario of CML, and where CML and Phe-negative MPN. Is it working? Yeah, okay, sorry. Where CML and Phe-negative MPN coexist. So today I will be discussing about the insights of the literature and about my research project. So for decades, CML and Phe-negative MPN were considered mutually exclusive. However, for the last 10 to 15 years, there have been more cases reported. And it's very important to recognize this clinical situation because it affects the diagnosis, the prognosis, and also the therapeutic. So here are the definitions of CML and Phe-negative MPN according to WHO and ICC. So as you probably know, the CML is characterized by the BCR-ABL1 fusion, while the MPN is characterized by the JAK2, CALR, or the MAPLE mutation. In terms of epidemiology, fewer than 150 cases have been reported worldwide, and it's mostly in small case reports, isolated cases, or regrouped in systemic reviews. And it's likely underestimated due to testing bias. And in the literature, the frequency of the co-occurrence of BCR-ABL1 and JAK2 mutation varies across studies. And it was seen in about 0.2% in one of the studies over 10,000 patients with MPN diagnosis. And interestingly, the combination of MAPLE and CALR mutations with BCR-ABL1 rearrangement is considerably rarer. And the clonal evolution occurred between 10 and 36 years after the original diagnosis. So there are three main models of biology. The first one is the sequential acquisition, where one neoplasm develops first and later a second driver mutation appears in a different clone. And 2 cases will be discussed later. The second model is the common progenitor, where both clones could arise from a common early progenitor, diverging after acquisition of different driver mutations. And a recent study by Naumann et al., it was published in July this year, it revealed that in 89% of evaluable patients with BCR-ABL1 had emerged in a pre-existing JAK2 positive clone. And the third one is the therapy-related evolution, for example, where a TKI suppresses the CML clone, unmasking a latent MPN. So let's talk about our research project based in London. So in response to the lack of knowledge about this uncommon situation where BCR-ABL1 rearrangement and MPN driver mutation coexist, we conducted an international multi-center retrospective cohort study. And cases were identified following a survey of international experts. And many variables have been collected, including demographics, disease characteristics, for example, MPN subtype, phase of CML at diagnosis, symptoms related to MPN, ELTS score. We also collected time difference between diagnosis of CML and Phe-negative MPN, treatment details, and outcomes. So thank you for not taking photos. I just cite this data because we are currently in the process of writing the manuscript. So in terms of results, with the help of many collaborative centers, so thank you for the Polish Acute Leukemia group, a total of 61 cases across 30 centers in 7 countries were identified over a 29 years period. So as you can see in the figure 1, 1 patient came from Quebec in Canada, where I come from, 26 from the United Kingdom, 4 from France, 16 from Poland, 6 from Italy, 5 from Kazakhstan, and 3 from Taiwan. So in the literature, there are 3 patterns of presentation which are recognized. So the first one is when Phe-negative MPN precedes CML. The second one is CML preceding a Phe-negative MPN. And the third one is when Phe-negative MPN and CML are diagnosed simultaneously. So in our cohort, so the group 1, it's Phe-negative MPN preceding CML. So 50.8% were in this group, and the detection of BCR-ABL1 was observed after a median of around 10 years. For group 2, CML preceding Phe-negative MPN, 29.5% were in this group, and the median time from CML diagnosis to diagnosis of Phe-negative MPN was about 4.5 years. And 12 patients were in the group 3, so 19.7%, and all patients were in chronic phase CML. So here, the table 1 shows the study and baseline characteristics. So you can see here the median age at first diagnosis is about 57 years. About 99% of patients had a history of thrombosis. And in group 1, the most frequent MPN subtype was ET, followed by PV and PMF, and 1 patient had an MPNU. And the most frequent MPN driver mutation was the JAK2 mutation. In group 2, so the majority had an ET as well, and 89% of patients had a JAK2 mutation. Out of 2 patients had a CALR. And in group 3, the majority had an ET, and 4 patients had an MPNU, 1 patient PV and 1 PMF, and the majority had a JAK2 mutation as well. Here, the table 2 shows the distribution of BCR-ABL fusion transcripts in the 3 groups. So you have the common BCR-ABL1 transcript and the rare transcripts. And I would like to highlight the A1, A2 transcript, which is much higher than as expected, because there was 13.8% in group 1, 16.6% in group 2, and the overall cohort, 13.7%. So if we compare to the normal frequency of the BCR-ABL1 transcripts, it's around 0.4%, which is much lower than what we had in our study. With regards to the therapeutic strategies, so here the table 3 shows the distribution of first-line treatment for Phe-negative MPN. So as you can see, Around 60% of patients receive hydroxycarbamide, 8 patients receive ruxolitinib, only 1 pegylated interferon, and around 23 patients were managed with active surveillance, including venedictions only. And for TKI, most of them receive imatinib. In this table, you can see the first-line TKI best response among patients with follow-up data in the 3 groups. So in group 1, most of them did not achieve a complete hematological response or a complete cytogenetic response. In the group number 2, most of them achieve an MMR or a DMR. And in group 3, it was well divided between no complete hematological response and a good response with MMR and DMR. And the median duration of first-line TKI was only 9 months for group 1, but 39 months for group 2 and 44 for group 3. So it may be challenging to interpret the best response to TKI because of the relatively short median follow-up on the first-line TKI in the first group of 9 months. However, it was largely explained by lack of response or resistance to first-line TKI. So regarding the progression to MF or advanced phase CML, the literature suggests that these cases can progress very differently. Some patients are very stable over time, and some patients progress to MF or acute leukemia. And in our study, in group 1, 11 patients progressed to myelofibrosis after a median of 10.5 years. And 1 patient progressed to blast phase, and 3 patients progressed to advanced phase CML, so 2 accelerated and 1 blast phase after a median of 72 months. In the group number 2, the progression to MF, there have been 3 cases reported, and in group number 3, there was no MF transformation, but 1 patient progressed to accelerated phase CML, and interestingly, this patient was the only one in this group with the A1A2 transcript. And in terms of prognostic outcomes, we look at the overall survival. So the median OS for the entire cohort was not reached at the time of analysis. But when we stratify by diagnostic sequence groups, so group 1, 2, and 3, the P was 0.05. So in group 1, it was the most favorable survival with a median OS not reached after a median follow-up of 156 months. The group number 2 had a median OS of 277 months. And in group 3, it had the shortest median OS of 100 months. Then we tried to stratify the OS depending on, according to different factors. So when we stratify by BCR ABL1 transcript type, it has demonstrated a statistically significant difference, as you can see in figure 3A. And when we analyze it according to ELTS score, driver mutation, and MPN disease, there was no statistical difference. We also look at the progression-free survival, and we define the PFS as the time to transformation to MF. So we analyze the patients with PV, ETR, and PNU, which includes around 50 patients. And the combined median PFS was 226 months. And as you can see in the figure 4 and here, we have 6 transformations for PV, 6 ET, and 0 in PNU, but there was no statistically significant result. We also perform an univariate analysis of factors influencing prognostic, and 2 factors, so the median age at first diagnosis and BCR ABL1 transcript P190 were associated with reduced OS. So this international multi-center retrospective study describes the largest cohort of Phe-negative MPN and coexisting CML. So I would like to highlight some key findings. First of all is the increase in TKI resistance. The E1 BCR ABL1 transcript, which is associated with poor outcomes. And the increased myelofibrotic transformation and accelerated disease progression. As I mentioned previously, in group 1, the progression of MPN to MF was around 35.4%. And if we compare this outcome with the expected progression rates to MF in MPN in general, It's much higher than the 4 to 11% for ET and 10 to 20% for PV patients. So it's important to identify early these cases and to have a closer monitoring. And we would like to say that it's important to screen for coexisting disease. If, for example, you have a persistent leukocytosis in Phe-negative MPN or persistent thrombocytosis in CML. And we may consider more aggressive treatment for patients with an A1, A2 transcript cases. So as mentioned previously, 3 biological hypotheses have been mentioned, and one of them was the sequential acquisition of mutation, and it was confirmed in our study for 2 patients. So we have performed a sequencing method, and we were able to identify both clones in both BCR-BL1 and JAK2 mutation in separate clones. So here are the 2 cases. For the first one, it's a 70-year-old male with a diagnosis of chronic phase CML. He had a low ELTS score, and he was treated with imatinib frontline and soon achieving an MMR. After 3 years of treatment, he exhibited clinical signs of accelerated phase, including a splenomegaly, although he remained in MMR. And he had a molecular reevaluation, and it showed the emergence of a JAK2 positive clone, and the bone marrow biopsy confirmed the presence of an MPNU. So he had started a concomitant therapy with hydroxycarbamide, but unfortunately the patient died 18 months after the MPNU diagnosis, while the CML disease was in complete cytogenetic response. And the second case is a 50-year-old female, a patient with a diagnosis of chronic phase CML, and the ALTS score was not determined, but the BCR-ABL1 was A14A2, and she received a first-line therapy with imatinib. She obtained an MMR, and 30 months later, she switched to dasatinib to achieve a DMR and discontinued the TKI. However, 5 years later, while she was in DMR, she showed a growing thrombocytosis, and CML disease restaging showed the emergence of a JAK2 positive clone. And the bone marrow biopsy revealed the presence of an MPN. So she started a concomitant therapy with hydroxycarbamide, and she's still alive and under clinical follow-up. So I think the biggest challenge in this situation is to recognize the second disease. And it's important and difficult to monitor at the same time the 2 clones, and it demands a coordination to monitor the 2 molecular markers. And at the moment, there's a lack of there's no guidelines, there's no official guidelines to treat the patient. So most of clinicians rely on case-to-case basis. So we need international collaborations to estimate the true incidence of these cases and to understand more the biology. Because at the moment, the natural history, the risk factors, and the optimal treatment sequences remain unknown. So it would be very interesting to have an international registries to look forward these cases. So integrative NGS might be very helpful, particularly for atypical cases. And early molecular detection may help to identify more specific treatments. And finally, wide-targeted combination therapy would be helpful as well. They do not exist, but maybe in a preclinical or future clinical trial. So I would like to highlight all the collaborators, including Marta, and I know probably there are some, some doctors who collaborate with me, the MPN team at Guy's Hospital, and the conference organizers. Thank you very much.
So now the session is open for the questions, if you've got any.
I have a question to Professor Schmidt. Could you please explain the bleeding complication after imatinib in cardiac patients? Because when we use it in CML, we don't see such
I know
complication
that.
at all.
I know that we discussed that problem during the Congress, as you could see 10 years ago, 2015 it was. And one of the possible explanation is the impact on PDGF receptor blocking. The activity of this receptor is completely different in patients with idiopathic pulmonary arterial hypertension and completely different in your diseases, hematological disorders. So as I can say, our patients from general cardiology may experience bleeding because activity of this receptor is different, and when we use imatinib and integrate the activity molecular pathways related to this receptor, platelet growth factor receptor, we can provoke bleeding. And sometimes we observed severe bleedings with unbeneficial outcome. This is the reason if we use imatinib now, this is the next drugs. We usually, as classical treatment is to use 3 drugs, and imatinib is the second one, off-label therapy in Poland, but colleagues from Japan, for example, prefer to use as classical treatment, but the Japan population may be different, as you can know. So in Europe, this is the off-label treatment as a POMOS and bridge to the lung and heart, sometimes transplantation.
As you're still sitting in the front, I also have a question, which is more politically oriented question. From my point of view, we have interactions between, or the cardio-oncologic interaction works well in larger centers, in university hospitals. How can we do better in bringing this information and treatments to the broader population that we are also having, that are not treated in centers? Do you have insights also from the discussions that you're having with your European colleagues?
Excellent question. We discussed in Europe about that, and the first step is developing of the team, cardio-oncology team. It is significantly easier in a university-based hospital. But in Poland, we have some cancer centers which treat CML, for example, and it's the huge problem to organize cardio-oncology team, including cardiologists with efficient experience in controlling and evaluation of patients with different cancer diseases. This is not so easy. In Europe, we have only few well-experienced teams. One is the UK, for example, in London, Alex Lyon team, and another one in Spain, Teresa Lopez Fernandez teams. I believe my team is well-developing team, and of course, this is a huge problem, because the current knowledge of general cardiologists is not efficient to support all problems for patients with cancer diseases, including hematological malignancies, and with induced different cardiovascular problems. It's not the same like general cardiology, because sometimes we observe the other activity, other profile of response for cardiac drugs, for example. So one example for the last experience, we prefer to use flozins for all patients with heart failure. We try to find the cancer diseases where flozins are safe, because we know that in some patients we may provoke cancer disease development or progression. So it's not so easy to use the same drugs from general cardiology and implement to cardio-oncology. So the first step is organize a team, cardio-oncology team, and of course the second point is cardio-oncology center of excellence. So there is the discussion about that, and now this year European Society of Cardiology decided to organize the first exam for cardio-oncology. So I'm interested how many people from Europe will pass this exam. So huge problem. Thank you for this question, but it's not so easy for daily practice.
Thank you for bringing it to the community.
Thank you for inviting me. It's a great pleasure to meet and discuss about not so easy problem for me. My experience is 20 years for cardio-oncology, not 20 years. I'm very old, so I apologize. And I still see lack of knowledge. I still need to learn more and more because you usually use newer and newer drugs, so the drugs can provoke me new problems. So one example, immune checkpoint inhibitors. The new phase of myocarditis, for example, not observed earlier in cardiology. Next question for me. Yes. Are you sure? Maybe microphone.
I was wondering whether you were looking also, because you were showing this beautiful division or maybe like, you know, some prominent difference between sexes and maybe some sensitivity to develop actually specific cytotoxicities between females and males, right? So I was wondering, is there like any further, you know, studies, you know, focusing on biomarkers actually between sexes? That would be the first question. And then second goes further. We are actually in Europe having more and more diverse racial communities. I was wondering whether you were also studying racial responses or basically correlation between race and then cardiotoxicity, because we know, for instance, that African Americans have actually like more pronounced susceptibility to develop, for instance, arterial hypertension or yes, some cardiological events. So yes, would you like to comment on that?
Two excellent questions, thank you. For the first one, when I preparing this lecture, I found the excellent paper. That's a pity that I didn't use it and to show you. There are some differences between female and male regarding the development of atherosclerosis in patients treated with ponatinib or nilotinib. Excellent paper. Next time I will present. But if you return the discussion about pulmonary arterial hypertension, I remember, I'm so old that I remember the time that this disease in general cardiology was typical for women only. Young women, different risk factors, but usually the development of this disease was associated with the hormonal status of women. And we usually observe, we have had the diagnosis of pulmonary hypertension mainly after pregnancy period, very typical. Now the situation is completely different because we observe older patients with pulmonary arterial hypertension and we observe more and more men. So the world is changing. Maybe it's one reason, but mainly there are other problems, maybe better diagnosis algorithms, for example, but maybe new etiologies, which was not new known area. This is one of explanations. So that was surprised that colleagues from France observe only pulmonary arterial hypertension in women treated with dasatinib, because in my center I have been working together with Professor Torbicki for more than 10 years. So we observe rather these disorders in men in Poland. It may be surprise, maybe differences between countries, I don't know. But mainly the situation of patients with pulmonary hypertension is changing during the time. So the answer, very simple answer for the first question. The second, I remember, and I'm sure that you remember, the data about the cardiotoxicity related to anthracycline. So we observe differences between countries and between continents. We know that black population may be understood at higher risk. I don't know such data for TKI used for CML. But I think we need to maybe plan or provoke to think about the registry with activity of different countries from different continents. Now I don't know if such registry may be planned. Maybe this is point to the discussion, for example, for International Cardio-Oncology Society or for European Society of Cardiology, but European is only one continent. Of course, we cooperate with other countries related to England, UK, Canada, for example, to Southern America, to Australia. We cooperate with Australia, but not the whole world is associated with cooperation with European Society of Cardiology. So I can propose colleagues from International Cardio-Oncology Society with leadership from the US, of course, but it's a good point to organize such registry and compare to different people from different parts of the world and define the risk of development of atherosclerosis or pulmonary hypertension. It's a good point for discussion for future.
Third question, follow-up question, any considerations for preventive measurements?
Okay, biomarkers. You asked biomarkers. Yes. Good point. If we would like to predict development of pulmonary hypertension or heart failure, because you should remember I didn't show that sometimes we observe pulmonary hypertension as complication of development, typical cardiac failure, left ventricular cardiac failure. So sometimes observation of people treated with dasatinib is very difficult, and echocardiography is very important to make differential diagnosis. And BNP is very helpful because we know that we observe increased level of BNP. We know that the problem of cardiac related to left or right ventricle is significant. And in this way, we can use biomarkers NT-proBNP, and we can conclude that echocardiography is necessary, and we observe the high probability of pulmonary hypertension. We should refer such patients to right heart catheterization and confirm the diagnosis by our invasive colleagues.
If confirmed, would you consider then actually the newest TKAs in this group of patients?
I don't know such data, but if you ask about the problem associated with atherosclerosis, you have not good biomarker. Of course, we can use troponin, but troponin is very helpful for acute event, not chronic. Of course, we can observe increased level of troponin, and we can expect higher level of ischemia, but it's not usually the indication for evaluation by invasive cardiologists. So we should be very careful to use troponin for evaluation of patients treated with TKI inhibitor, TKI due to CML. NT-proBNP is very good for development for predicting of heart failure or pulmonary hypertension, but troponin is also good for evaluation of patients treated with TKI, nilotinib, and dasatinib, and of course ponatinib. And sometimes dasatinib, because we know the data that dasatinib may provoke cardiac ischemia or occlusive arterial disease, but the frequency is significantly lower in comparison to ponatinib or nilotinib, of course.
Thank you.
Professor Schmidt, thank you so much for a wonderful presentation. I'm actually a colleague of Alex Lyons. He takes my patients from London for cardio-oncology advice.
I'll write to Alex.
I took a picture of you and sent it to him, and then of your slide with his photograph on it. Just to say that in London, the way that we've just starting to develop a way to stratify patients. Just a comment that we use a national indicator called the Q-Risk3 score, which is based on multiple factors that we would all expect, like smoking, family history, migraine, but also postcode, body mass index, etc. So we would refer to Alex in those settings, but I think we don't even have it perfect. And then I just wanted to ask Laura-Lee a question because she gave such a fantastic presentation.
Thank you.
If that's okay. And sorry, Laura-Lee, I didn't give you this question to start with before you got up. Why do you think that most of these cases have a JAK2 mutation, not a calreticulin mutation? Do you think there's something about the biology of JAK2 mutations, or do you think it's a more prevalent mutation? I'll pass you the microphone.
Oh. Problematic question because, okay, the question not for me, for colleague. Okay.
For me. Yeah, okay. Thank you, Prof.
But I would like to thank, and I will send the greetings. Yes, I will try from a cardiological background. I'm so sorry, but I would like to thank for the congratulations, and I will write to Alex because we plan to cooperate very closely. Alex is my friend. It's not. This is very clear. We cooperate very closely, and we plan some new research trials, and I think that our countries will be more close, UK and Poland. And lastly, we organized a special meeting in Warsaw, and British Embassy was our patron because Alex Lyon was one of the speakers. So I'm so sorry. Yes, I agree, completely agree. I'm so sorry once again.
Thank you, Prof, for your question. So yes, it's a very interesting question, and to be honest, I'm not sure about the answer, but I think it's just the JAK2 mutation is the most frequent mutation in general in MPN. So I don't know if the percentage match with the percentage expected in MPN, but I think it's more because of the most frequent mutation, which is JAK2 mutation in general. It could be interesting to look at this.
Yes, Natalia.
Very strong question. Also describing that actually this very specific group is in fact also showing higher resistance to TKAs. I was wondering whether you were also looking into other myeloid mutations that may co-occur in this subtype, and maybe that would be the reason of the TKA resistance or any other mutations.
We have collected data for additional mutations. It's not everyone who had an NGS because it's not in the guidelines, but for people who had an NGS, we found some ASXL1 mutations, DNMT3A or TET2 mutations, but it was difficult to correlate these additional mutations with the TKI resistance or transformation to MF or accelerated phase. But we have discovered some patients with additional data, with additional mutations and abnormal cytogenetics. But it's difficult to put everything in the same picture and to conclude to something. Yeah. Thank you for your question.
I think it's time for a short break, coffee break, and we've got the last session. I think that's very interesting, so please come back.
Szanowny lekarzu, zwracam się do lekarzy SOR, chirurgów, internistów, także intensywistów. Jeżeli twój pacjent ma rozległe, występujące nagle wynaczynienia podskórne krwi, zwłaszcza jeżeli jest to pacjent w podeszłym wieku, nadto wywiad osobisty oraz rodzinny skłonności do krwawień jest negatywny, a w badaniach laboratoryjnych stwierdzasz izolowane wydłużenie APTT, to może to być nabyta hemofilia A. W takiej sytuacji powinieneś jak najszybciej skonsultować się z hematologiem. Tylko szybkie potwierdzenie rozpoznania i wdrożenie właściwego leczenia będzie skuteczne w leczeniu chorego na nabytą hemofilię A. Rozpoznaj, skieruj do hematologa, uratuj ludzkie życie.
To introduce Claire Woodley. She's a nurse working with Claire Harrison, and she will tell us a little about the nurse work. And please, Claire.
So thank you very much for this opportunity to come here and to discuss how in the UK, and more specifically at Guy's and St Thomas's, we have developed the nursing role within managing patients with myeloproliferative neoplasms. Maybe. No, maybe not. There we go, lovely. Thank you. There we go. So within the UK, there are many different opportunities for nurses to develop in their career pathways. And our patients with MPN will come into contact with many different nursing roles, such as nurses that are based on wards, practice nurses, research nurses, clinical nurse specialists, palliative care, and even nursing associates. I thought I'd just kind of, first of all, give you a little bit of background into how I developed in my role. And I qualified way back in 1997. And commenced my career in an inpatient ward managing haematology patients. So throughout my career, I've only ever worked with haematology patients. And as an inpatient ward nurse, I worked my way up to being a ward sister. And it was during this time that I was able to develop and to have the opportunity to participate in a number of courses that enabled me to develop my specialism. So that involved a haematology specialised course, oncology, chemotherapy training, and critical care training as well. Then in 2004, I moved from my local district hospital to Guy's and St Thomas's, which was where I met Professor Harrison. And I began my journey in our haematology day unit. And this was where I worked across our haematology specialists, but when I first came into contact with patients with MPNs. Now, during my time in the day unit, again, I was able to develop yet further skills in apheresis, chemotherapy administration, venesections, and dealt with, as I say, patients that both had hematological malignancies as well as our non-malignant patients as well. Then in 2008, I became a haematology research nurse, and this was the first time that we'd actually had a role of a research nurse in myeloproliferative neoplasms. It was a joint role with sickle cell, so I covered both subjects. But actually, it was an exciting time for MPNs because it was when we first had the first clinical trial with ruxolitinib. And for us in the UK, we were one of the highest recruiters at Guy's and St Thomas's onto the Comfort 2 studies. And then after that, there was a real influx of more studies for patients with these conditions. And actually, it was where my passion for nursing MPN patients came from. And then in 2015, I moved into a clinical nurse specialist role. And then in 2021, into an advanced nurse practitioner role. And it's these two roles that we will focus on in this presentation. So what are clinical nurse specialists? Well, they play an essential role within the multidisciplinary healthcare team, providing expert support, education and guidance to patients and their families throughout their care pathway. From the initial investigations and diagnosis through to treatment, and where appropriate, palliative care. The clinical nurse specialist ensures that continuity of care and facilitates communication between patients and clinicians and helps individuals to make informed choices about their treatment. Evidence shows that when clinical nurse specialists are involved in patients' care, there is an improvement in their satisfaction. It enhances their adherence to treatment, reduces hospital admissions, and contributes to better clinical outcomes. There are further studies within cancer care that equally show an improvement in patient outcomes, but also in improvements in patients' knowledge and management of their symptoms. Guidance from our Department of Health and Macmillan Cancer Support, which is one of our national charities, summarises many, but not all of the key contributions of the clinical nurse specialists. You will see on this slide some of the roles and advanced things that we do. So nurse specialists have advanced clinical diagnostic skills. We have an in-depth knowledge of a particular tumour area, the ability to assess patients' holistic needs, as well as being trained in advanced communication and advocacy skills. Like many clinicians, we have empathy for our patients and their families, excellent decision-making skills. We're key members of the multidisciplinary team and the wider cancer team for our patients, but are also involved in project management, development of services and change management. Now, my role as an AMP builds on this work, and it's more of a, probably as I've grown, more of an expert in managing patients within this group. Not only do I physically assess patients, but I will have an independent caseload of patients that I manage. I will see patients in our consultant clinics, and that goes through from diagnosis through to treatment decisions, through to prescribing treatments, checking their response to treatments, and discussing treatment changes with our patients. How does this translate into the haematology clinical nurse specialist? Well, this is a quote from our British Society of Haematology and really just summarises what was said on the previous slide about that nurses have advanced knowledge and experience and practice autonomously through nurse-led clinics and ward-based educations whilst working within the multidisciplinary team to support patients. This is our myeloid specialist nursing team at Guy's and St Thomas's. We have 4 nurses within our team. There's myself as the advanced nurse practitioner, and I manage our team of CNSs. My clinical focus is on MPNs and CMLs, but I also manage our MPN patients through our obstetric clinic. My colleague Susan again focuses on MPN, but she also manages our systemic mastocytosis patients. Vanessa manages our MPN and CML patients. And then Laura is our CNS who works in our leukemia service and our MDS service. She also has a list where she independently performs bone marrow biopsies in our day unit and is currently working on developing an advanced care planning clinic for our patients. So what does our role entail and how do we use our skills within the MPN service? So as I've already mentioned, we're core members of the multidisciplinary team. And this is where we can advocate for our patients in team meetings or when patients' cases are discussed, because we are that patient's voice in that meeting. We know what our patients want, and we can act and talk on their behalf when treatment decisions are made. We act as a key worker for our patients. This is a concept that was introduced through reviews of cancer services in the UK, and it's supported by our National Institute of Clinical Excellence. They advocate that each individual with a diagnosis of cancer should be allocated a key worker. The CNS as a key worker is a person who, with the patient's consent and agreement, takes a key role in coordinating the patient's care and promoting continuity, ensuring that patients know who to access for information and advice, and providing them with emotional and supportive care. And it supports patients throughout the whole diagnostic journey, their treatments, and providing that continuity and for patients to know who they can access between their clinic appointments. So if we have a look at the patient journey, and this shows us from when the patients are first present with symptoms, through their diagnostic tests, treatment choices, as they continue on their therapies throughout their journey, and then living well with their MPNs, and unfortunately for some patients, a disease progression. The CNS is active in each stage of this patient's journey. We make sure that there are at key stages the CNS is always present. So if a clinician is talking about a diagnosis with a patient, then we try to make sure that a CNS is present in that diagnosis so that they're able to reinforce with patients what has been said. Our patients have a designated helpline number which they can use in order to get in contact with their nurse specialists between their appointments. Equally, they can email us if they have a routine general question. And out of those hours, we rely on the support of our acute oncology clinical nurse specialists who provide a 24-hour helpline number for our patients. So if they are unwell and it's 2 o'clock in the morning, then they can ring a nurse and ask for advice on what they should do at that time. So how does that transcribe into a patient case? So this was a 39-year-old gentleman who was originally referred into our service and was awaiting his first appointment. But in that time, he presented to A&E with worsening of his symptoms. And as you can see here, his counts were all elevated. The nursing team was highlighted to this patient's attendance in A&E and was followed up with a phone call by myself to arrange a visit for him to come into our day unit to be assessed. Now, in that day unit appointment, I did a full history with the patient, full examination. We went through all the the systems, arranged all of his diagnostic testing for him, and spoke about the potential diagnosis. It then meant when that patient then came into clinic 10 days later, we already had his molecular results, and we could then move on to arranging the next series of tests, which included a bone marrow. He was then seen regularly in our day unit by the specialist nursing team with a lot of psychological and emotional support for this patient who was finding it very difficult to not have a full diagnosis and to learn how he could then manage his condition. We were there when he was having his venesections, and quite often he would follow up with emails to the nursing team. Then in May, he had an appointment with the consultant and the CNS, and he had a discussion about the results of his bone marrow biopsy confirming his diagnosis, and a treatment plan was discussed with him. Again, he then remained under our day unit for a short period of time, with the CNSs arranging his repeated visits for his venesections. Following on from that, a decision was made to start him on therapy. And as nurses, we arrange and we talk through administration of medication to patients. We go through potential side effects, and then we arrange their follow-up tests once they've started on their treatment. So where is he now? He continues on his treatment with pegylated interferon, and he gets reviewed routinely now in our outpatient clinic. I think through the support that he had at the beginning, he really doesn't have much contact with the CNS team now. However, I might review him in a consultant clinic and assess his response and prescribe further treatment for him. In enabling him to live well with his condition, it was around empowering him to manage, empowering him to know the symptoms to be aware of, when he should escalate concerns, and how he could self-manage some of his concerns. We referred him to a lot of supportive services. We have an excellent service by our OTM physio for helping patients to manage fatigue. And he always and still does have access to the nursing team through emails and through telephone support. If we look at another case, a 54-year-old lady who was diagnosed with PV and a history of Budd-Chiari. Now, she was being managed through my telephone clinic, and where she would have her bloods monitored remotely. We'd decide whether her response to her treatment, how her symptoms were, and again, if we needed to make any changes to her treatment. It was actually identified through that clinic that actually she was resistant to her hydroxycarbamide. She was continuing to have increased need for venesection, but I couldn't escalate her dose because of cytopenias. So therefore, I had a discussion with her around alternative therapies and what we could use for her, and then advocated on her behalf with our wider consultant team to then be able to bring into clinic to consent and to start new treatment. She was again counselled on her treatment by the nursing team and now continues on regular monitoring, again largely by myself in our clinics. Our next case is a 38-year-old female who was diagnosed with ET in 2024. And I'm highlighting this one because actually she was referred into our service at Guy's and St Thomas's, but actually it was all done through nursing. So her local nurse CNS was in contact with myself about how we could better manage her symptoms. She was particularly struggling with fatigue. So we referred her into our clinic at Guy's so that she could see the consultant, but largely so that we could refer her into our supportive services that we have that unfortunately weren't available at her local hospital. She was seen by the consultant and then had a conversation with myself. And it was through that conversation that we were able to identify the actual psychological distress that this patient was experiencing. The impact that it had on her identity, her role and her behaviours, and how this was changing how she was able to live with her condition. We were able to look at her sexual health and intimacy, and she was really particularly struggling with this aspect. And again, for her, it was largely around fatigue, but it also needed to be spoken about that there were many contributing factors to her fatigue. So being able to support her in understanding fatigue and how fatigue in MPNs might present for patients. Following on from that, she had a number of referrals that I was able to make for her into our psychology service, to our OT and a physio again, into local talking therapies, and actually able to identify a sexual health counsellor that she could then go in to see as well. And in this case, finally, this is about a lady who's been under our service for many, many years and is more around identifying progression in a patient. So she contacted the CNS between her appointments because she'd had a blood done in a different hospital for a completely different reason, and it had been flagged with her GP. So she then rang the CNS team to explain the results. We were then able to do some routine, wider testing, speak with our consultant team, arrange for tests such as bone marrow biopsies, all to be completed. She then came into clinic and was given the diagnosis that her disease had unfortunately progressed. And again, it was around treatment changes, and the nursing team supported and counselled her on her different treatment. And in that immediate change of treatment, the follow-up blood tests were performed with the CNSs following up on those results, discussing with the clinical team if needed, and then if there were any amendments that needed to be changed to her medication. There was again another element around psychological support for this patient, and equally supporting her family through the change in diagnosis, and also a young lady that was working, but actually her symptom burden had increased significantly, so it then had an impact on her work. And as nurses, we will often write supportive letters for our patients to help them explain to employers how they might need to change their working hours, or in recognition of the impact that living with these chronic conditions can have for our patients and what it might mean for them in long-term career prospects. So another large area that we do, and is a real area where I'm really quite passionate about, is managing symptoms for our patients. Because I think for our patients, they are living a long time with chronic conditions with quite often invisible symptoms. And often they may present, and quite often patients will say, oh, people say to me, I look well. And inside they are struggling with this whole burden of a lot of symptoms that quite often they don't know how to convey to their family, to their friends. And quite often the biggest one that, as we all know, for this patient group is fatigue. So when we look with symptoms with our patients, we're looking at and trying to encourage our patients to monitor their symptoms. We do try to implement in our clinics the MPN-10, so that patients, when they present in clinic and check in, they can get one of these forms so that they can complete it and then take it into the clinic room with them. So it opens that discussion for our patients. Equally, patients in the UK can access an online tracker so that they can do it at home, and then they can email their results into their nursing team so that we can upload them into their electronic records ready for their consults. And we are quite fortunate that we have done a lot of work with our national patient charity, MPN Voice, and have developed an app which patients can use. And part of that app is they can have access to their symptom scores again. So patients are encouraged on a daily basis to record their symptoms. For me, quite often, outside of the app, I might not tell my patients to report symptoms every day, but certainly do to monitor their symptoms between their visits, maybe once a week, and certainly to flag if they are finding that there are symptoms they cannot manage or there are symptoms that are getting worse for them. And quite often patients will ring up through our helpline and ask to speak through their symptoms, or if they've got a symptom they're not sure about, then they'll ring up and ask for advice. And that might be us signposting them to other services when it's perhaps not related to their underlying condition. With this patient, I just wanted to highlight, it's not so much about her case, but actually about her management of her symptoms. So this is a lady who's been in our service for quite a long time, and she's been on ruxolitinib for her PV since 2016. She came into a clinic with me and she was just near enough on the floor. Her MPN-10 score, as you can see, was 50. She was scoring 10 for a lot of her symptoms. And for this lady, fatigue has always been a real significant problem for her. So we spoke about how we can manage fatigue. And that's not wrong. We know that there are the medications that can help with fatigue, but I do spend a lot of time with the patients breaking down what fatigue means for them, how it impacts them on a daily basis, how do they cope with it, how do they manage it, what are the other things that we can do that can help this patient group manage fatigue from a non-pharmacological perspective. So that's around looking at their levels of activity, their diet, what they are doing, what they aren't doing, how are they planning their days, how are they, pacing activities, how might they be prioritizing what they do. And I must admit, the majority of my consults, we always end up talking about fatigue. And it is a good 10-15 minute consult each day. And I probably do it when I'm seeing about 9 or 10 patients in a clinic. 3/4 of them will have a conversation about fatigue with me. But equally for this lady, you will see that some of her other symptoms were quite high. And on it being able to explore further, we were able to identify that actually her fatigue was really being impacted by a lot of other contributing factors. She was perimenopausal, so there was a large overlap of symptoms for her with that. She was quite depressed. So again, it was not just about managing that MPN symptom, but equally about liaising with her GP around reviewing her antidepressant medication, about reviewing medication for menopause. 6 weeks later, she came back to me in clinic. Her MPN score had halved, and she had done some of these things and some of the techniques that we had said about in kind of pacing activities, in making sure she had a daily walk, in setting small goals. So, you know, it was quite an achievement that she could then see how she could change what she was doing in order to manage her symptoms. So moving on, looking at some of the other things that we do within our role, we have a large part in educating our patients around their diagnosis, around treatment, around lifestyle changes, nutrition, family, child, literally anything that is covered within a clinic, that our CNSs will act on patient education with them. We do a lot around medicines management. So when our patients come in and when they're on a treatment or when they're starting a new treatment and they've been consented by the clinician, the patients will get a pre-chemo consult with our clinical nurse specialists. And that's when they will go through the medication again with them, ensure they understood the consent process and the potential side effects of the drug, ensure they know how to take their medication, how to store their medication. They teach them a lot about how to administer pegylated interferon. We will talk about interactions with other medications, when to escalate things. We will look at when follow-up bloods might be needed and make sure they're booked and then follow up on those results. We have 3 consultant clinics a week, and our CNSs in those clinics are key work in their patients. So they're there, they will go and sit in consults, the patients might be in the waiting room and might say, can I have a word with you? Can you help me with this? Can you provide some support on this? For myself, within those consultant clinics, I have an independent list where I will see patients. So I will see patients from a PV patient on observation to a complex myelofibrosis patient who's on their 3rd line of treatment. So I really do see across the spectrum of our patients, and we'll do exactly everything that you as clinicians will do with your patient in that clinic. We then also have nurse-led clinics. So these are independent clinics where there is no medical clinician on them. So my colleague Susan runs a venesection clinic, and that's for PV patients and our secondary erythrocytosis patients. And I have a telephone clinic where perhaps our patients don't need to come into clinic, but they can have remote monitoring, and that will again be patients across the spectrum on or off treatments. We have our day unit, so sometimes if patients are unwell in between appointments or they might need to have a blood test between appointments, then we can bring them in through our day unit. And there, our day unit is run by nurses and some of our junior doctors, but equally they rely on our clinical nurse specialists for that more MPM-focused input for these patients that are coming through our day unit. As I already said earlier, I look after our pregnant ladies, so we have an obstetric clinic that's a haematology obstetric clinic, but I will go down and I will sit in and review our MPN ladies through their pregnancy journey and then bring them back to our main clinic. It's probably one of the highlights of my job when I get to see all the little babies, which is really positive, and it's good to be able to convey that to some of our younger patients that are coming through, that this is possible for them. We have a support group that we run, which is a virtual support group. It meets every 2 months, and our patients can come online, and we have guest speakers, and it's really a way that we can have our patients have access to other patients and have that peer support from them. But equally, we're also involved with our national patient charity, MPM Voice, and support them with their forums that they run around the country. And naively, I'm running the London Marathon for them, which is a bit of I don't run for a train, so I'm a bit freaked out by having to do 26 miles. But, you know, MPM Voice is such a good charity that supports our patients so well. And if I can give a little bit back to what our patients do, then, yeah. And then we're also involved in service development, and that's audit, quality improvement, protocol writing. One of our nurses has just recently completed a fantastic audit where she looked at our myelofibrosis patients and our completion of the MPN-10 with these patients. There's some interesting findings which I won't share because Prof doesn't know the outcome yet, but largely around how well we might discuss symptoms, but how perhaps we might look at MPN-10s, but perhaps not put that score in those patient notes. Interestingly, the nurses do. And then we're also involved in teaching. So not only teaching of our patients, but actually participating in teaching on a national stage with colleagues around the country on specialised nursing days. So we've been running an annual nursing day for our nurses, allied healthcare professionals and pharmacists on MPN, so where they can have updates and talks and things just so that we can keep our knowledge and share best practice. I could stand here all day and say to you that nurses are fantastic, and we have really, in the UK, we are so fortunate with how we are able to develop our skills and to develop our clinical practice. But nothing sums it up better than our patients. This is a quote from one of our patients who was diagnosed with PV. And she's just highlighting about how times can be challenging, but actually having that constant person, that's somebody with the expert knowledge, that when she's feeling overwhelmed is there for her, who can support her when times are difficult. And then this is just another patient who again speaks about the comfort of having that same person as a point of contact, someone who knows you, your partner, and can see you through the tough times. That when you're sitting in the waiting room and you see that your nurse walk past, it cheers you that you've got that familiar face. If there's a deterioration or a worrying new illness, it helps you to know that there's someone you can speak to on the phone or email. And sometimes your nurse will detect a concerning condition or complication and without prompting will contact the necessary department, and before you know it, a dietitian or a doctor will appear. Thank you very much.
Thank you, Claire. I'm really jealous about how you work, and maybe we can just establish a little part of your work here in Poland. Thank you. Okay, we have to follow with the session. You've got these flowers. This is for voting. Okay, we will have 4 clinical cases. The first one is only video case, so we are not going to vote, but the 3 of them are to vote. So our colleagues will present the cases, they will ask some questions, and then you will choose the color of the response, okay? So we will start with the first case. My colleague Martina Bertinger from Switzerland, from Winterthur, she will present a really interesting case online.
Good evening, everyone. My name is Martina Bertinger. I'm a medical oncologist working in Switzerland in the Canton Spital Winterthur and in the Inselspital in Bern. Unfortunately, I cannot be with you for the Congress, but I'm very happy to share a case with you. So the case is about a 62-year-old patient. He was known for recurrent macrohematuria. He had no allergies, but somehow a sensitive gut. He's a current smoker, originally from Kenya, and works as a nurse. So the patient was referred to our clinic by the family doctor due to persistent anemia and systemic symptoms. And for his history, it is to know that he visited his family in Kenya the last month, and there he had another episode of macrohematuria and leukocytosis. So you see the blood, where also the results of the blood examination on the right side. So he had a leukocytosis and a decreased hemoglobin. So he was treated with an antibiotic therapy, but back in Switzerland, he had a persistent dizziness, fatigue during exertion, and coughing. He had otherwise a normal appetite, no fever, no night sweats, and no weight loss. So in the physical examination in our clinic, he was in quite a good general condition. He had a stable weight, no lymphadenopathy, and no palpable splenomegaly. So these are the results of his blood. So he had a decreased hemoglobin, a hyporegenerative normocytic normochromic anemia, and a leukocytosis with a predominant eosinophilia with a few myeloid precursors. Otherwise, in the chemistry analysis, CRP was not elevated, and he had good renal and hepatic functions, mildly elevated LDH and B12 level, and a significantly elevated tryptase level of 70 micrograms per liter. So our tentative first diagnosis was a myeloproliferative disorder with eosinophilia, and we decided to go on with imaging and a bone marrow examination. So here you can see the PET scan. So he had mild splenomegaly of 15.5 centimeters, a generalized but very mild lymphadenopathy, and a chronic occlusion of the extrahepatic portal vein. The bones were, there was a change. He had a diffuse multiple sclerotic lesion. You see an example marked with the arrow on the right side in the sternum, but also in the pelvis and the vertebral bodies. So next step was a bone marrow examination, but we were actually not successful. The bone was that hard. It was a punctia sicca. So we referred the patient to our radiologists, and they performed a core biopsy of the os ileum. And you see in A, he had a packed marrow of 99% cellularity, a massively proliferated myelopoiesis, no excess of blast, and increased hypolobulated eosinophils marked with the arrow. So we found then muscle aggregation. They were in loose, non-cohesive clusters. They were hypogranular in the cytoplasm and had a round nucleus. Immunohistochemistry showed a positivity of CD25, CD117, and tryptase, and negativity of CD2 and CD30. We also found megakaryocyte clusters of hypolobulated morphology. And then perhaps the explanation for our not successful bone marrow biopsy, osteosclerosis grade 1 and myelofibrosis grade 1. So now, due to this mast cell aggregation and the elevated tryptase, our tentative diagnosis was a systemic mastocytosis, and we performed a molecular analysis. BCR-ABL was negative, and also the NGS-MPN panel, and a bit surprisingly, also the KIT mutation. At this time point, the chromosome analysis and FISH analysis were pending. So what do we do now? So what is our diagnosis? So we were quite sure that we have a diagnosis of a systemic mastocytosis. Almost all except the KIT mutation point was met, and we went further. So the patient wanted to go to Kenya once again. We had an indication for a systemic therapy, and we decided to perform a limited steroid trial. So we gave the patient 1 milligram per kg prednisone, and the goal was really to improve the anemia and the gastrointestinal symptoms and also the cough. Additionally to the steroids, we gave the patient disloratadine, an antihistamine, and an EpiPen, and we treated the thrombosis with a rivaroxaban, and the patient went off to his family to Kenya. And in the meantime, the outstanding results, the fish and chromosome analysis results came back. And here you see the karyotype and the fish. So he had a FIP1L1 and PDGFRA rearrangement. So now we went back to the textbook, and as you see here, there is a small writing under the box in the absence of a KIT mutation, particularly in cases with eosinophils, the presence of tyrosine kinase gene fusion associated with mLNEO must be excluded. And so we now could change the diagnosis to an mLNEO with TK fusion. So mLNEO with TK fusion is a very rare disease, and there are a lot of important differential diagnoses which can confuse us clinicians, and typically they have an extramedullary involvement. So it's typical that they have an excellent response to tyrosine kinase inhibitor like imatinib, which not only inhibits ABL but also KIT and PDGFRA. So when the patient came back, we started therapy with imatinib. In this disease, we can use lower doses of imatinib, in this case 100 milligram per day. And as you see on the right side, he had a remarkable response 2 weeks later. He had a normalization of the eosinophils and also the improvement of the hemoglobin. He had no more constitutional symptoms, no gastrointestinal symptoms, and no coughing. And he tolerated imatinib very, very well. And so we conclude with this case, mLNEO with TK fusions. These are rare myeloid lymphoid neoplasms. They derive from a pluripotent stem cell. They lead to constitutively activated tyrosine kinase. They can be confused with other myeloid neoplasms, which almost happened to this patient as well. It needs to, for diagnosis, the karyotype and FISH, and the patients show mostly a high response to TKI therapy. And so I'm already at the end of my case. Unfortunately, I cannot discuss, but hope that I can be with you next year in Poland.
So we follow over the clinical cases, and now I ask Olga, 1 week ago Czurko, now Demska, to present her case.
Good evening, everyone. Thank you for coming such a long way here for this conference. I would like to present a really short but very interesting, I hope so, case report about acute myeloid leukemia. So, what is patient profile? She was 61 years old, ECOG 3, some days was 4, but mostly 3. Symptoms besides pancytopenia, it was skin infiltrations a lot, pulmonary crepitations, and lower limb edema. She was initially hospitalized at internal medicine department, and her medical history was hypothyroidism, bicuspid aortic valve, depressive disorders, different surgeries. And when she was at internal department, they diagnosed hypogammaglobulinemia and multiple deficiencies, vitamin D, K, calcium, albumin, and folic acid. Besides, she had a lot of recurrent infections, Klebsiella NDM plus colonization. And firstly, we were as consulting doctors, And during her hospitalization at internal disease department, she had acute renal failure, even deeper pancytopenia, pneumonia, UTI, severe abdominal pain of unclear etiology. And when we consulted her, we tried to perform bone marrow biopsy. But unfortunately, we tried, I don't know, I think about 4 or 5 times sternal, a few times hip bone, and it was dry tap, no bone marrow aspirate. Otherwise, we have no karyotype available. So, internal doctors went with this severe abdominal pain and performed gastrointestinal biopsy. We did not have any findings that could help us in our diagnosis, and it was hard for this patient to manage different infections. And we decided to go with defined biopsy. Defined biopsy shows us myelofibrosis stage 3, and she was about 2 or 3 months in internal department, and it was very hard to manage different infections complication, but after that she was transferred to our department. And to the time when she was transferred to us, she had progressive leukocytosis till 40,000. She required multiple red blood cell transfusion and platelet transfusion. Bone marrow aspirate was still unavailable, unfortunately. And we went with flow cytometry from peripheral blood. As you can see, first one was at the end of March this year, and there was no evidence of clonal B-cell or plasma cell population. There was some suspicion of dendritic cell leukemia, and this is how her skin looks like. You can see a lot of here, a lot of skin infiltrations. It was raised above the skin, and it has a really purple border. So, what do you think we should do next? Treat her as a primary myelofibrosis and start with Ruxo, perform skin biopsy of the lesion and repeat peripheral blood flow cytometry, repeat refined biopsy because from the first one it was 2 months, or delay treatment until we can get cytogenetic results. Okay, I see. We don't know the right answer, actually, but we also went with performed skin biopsy of the lesion, and it helped us a lot. Actually, it was Professor Marta Sobas who performed the skin biopsy by herself. And skin biopsy revealed that it was AML with monocytic differentiation. So from the time of first symptoms till the diagnosis, it was about 4 months, very, very long period of time. Flow cytometry also confirmed our diagnosis. It was AML with monocytic differentiation. And final diagnosis was AML, FLT3 minus and PM1 minus from the blood because we still didn't have any bone marrow. ALN risk intermediate, we don't know actually because we couldn't manage to have any karyotype even from the blood. And due to old classification, it was AML M4. So we started our treatment with Venasa. It was only for 6 days. Normal dose, 100, 200, 400. At the end of April, we performed lumbar puncture, and also she got methotrexate and RC intracecal. In a cerebrospinal fluid, there were no blasts. And this was her skin after only 6 days of treatment. So you can see that here only bruises after azacitidine shots, but no really lesions there was before. And unfortunately, we withdraw venetoclax temporarily because she had a lot of complications. She had even deeper pancytopenia with neutropenia, sepsis with 3 bacteria, Klebsiella endem, Staphylococcus, and E. coli. She had also cardiorespiratory failure. She requires oxygen. She requires vasopressors. I actually spoke to her husband, and we were telling him that this might be the end, and we don't have any more treatment for her. This is just to show you how really resistant was this bacteria. So to treat sepsis was really, really hard for us and challenging. And what would you do in this case? Would you restart venetoclax in this patient after managing sepsis? Immediately at full dose, with modifying dosing, permanently discontinue due to high risk of infections, or wait for complete cytogenetic reassessment before starting. Okay, we went with B. We give her modifying dosing. We reduced dose of venetoclax and also strict anti-effective prophylaxis. And she was discharged home. We repeated lumbar puncture and still no blast was there. Restarted venetoclax and continue venetoclax in outpatient clinic. Unfortunately for this patient, she had 4 months of survival, but she was in really very hard state, and we really thought that she would die in April, but she had 4 more months with her husband at home, and her husband actually called us a few weeks ago and was very thankful that she can spend rest of her life at home with him. And here's just to show you, it's here where when she was transferred to our clinic, and after we started venetoclax treatment, venetoclax with azacitidine treatment, leukocytes was stabilized, and she did not require any transfusion, even blood cell or red blood cell or platelets. So when she was at home, she really just came to our clinic for more venetoclax pills, and that's all. So to take home message is AML M4 with skin involvement is very, very rare and atypical presentation. We had not specific clinical picture, only abdominal pain, pancytopenia, recurrent infections, and all of this delayed our diagnosis. Actually, firstly, at the beginning, when we only had pancytopenia and this lesion, we also thought it may be dendritic cell leukemia, and only actually skin biopsy helped us to have a right diagnosis. And sorry. So here, even we don't have any bone marrow aspirate, we perform peripheral blood flow cytometry and skin biopsy, and it was very helpful. As I mentioned before, due to no karyotype, it was limited ELN classification, but in this case, if it was high or if it was intermediate, it's doesn't matter, because she received venetoclax with azacitidine, and in this case, really interdisciplinary cooperation was very, very helpful, because we were treating her with internal medicine, with anesthesiology, microbiology, and also our diagnostic department, and all of our cooperation was essential for diagnosing and treating this patient. I know it might be not a happy end, but at the end, maybe 4 months of life was worth it. Thank you.
Olga didn't tell you, but once she saw the skin changes, she told me this is monocytic leukemia. I know it. So this is one point. And the second one, she's got TP53 mutation. So we know it later on. Okay, so Marta Kuidowicz from Krakow. She will present the next case. Please, Marta.
Thank you very much. My name is Marta Kuidowicz. I work in the hematology department of Kraków University Hospital. And actually, today I'm going to show you a comparison of two cases of acute myeloid leukemia with NPM1 positive and FLT3 TKD positive mutation profile. First, I'm going to show you the general diagnostic overview of both patients, and then we'll compare the treatment schemes and the treatment results. Our first patient, Mr. K, is a 48-year-old male who presented to us in May of 2025 with a history of fatigue, loss of appetite, night sweats, and weight loss of 8 kilograms since January. On physical examination, there was no organomegaly and no lymphadenopathy. He suffered from gastric reflux, hemorrhoids, had an appendectomy, but what stood out to us in the medical history was a history of cytopenia in 2024. He couldn't provide us with the test results, but he only said that he received B12 supplementation. Also, he had a major risk factor of 19 years in the rubber industry, so nitrosamine exposure. His CBC showed pancytopenia with monocytosis. His bone smear and flow cytometry confirmed the AML diagnosis. His karyotype was normal, and molecular findings showed the presence of nucleophosmin mutation and FLT3 TKD mutation, which put him in the favorable risk group according to the ELN guidelines. His CT scan showed a slight splenomegaly, his heart function was perfect, and his comorbidity score was 0 with an ECOG performance status of 1. We arrive at the first question. What would you think is the best treatment for this patient? Would it be A, maybe red, 3+7 induction chemotherapy treatment with midostaurin, or maybe B, Vyxeos, due to history of cytopenia and 19 years of toxic exposure, maybe, let's say, blue. Please vote. Well, I'm glad because that's also what we decided, but luckily, due to those two factors that made me suspicious at first, we performed trephine biopsy at the beginning, so it luckily helped us with the picking of the treatment because it showed no dysplastic changes in any of the cell lines. So we decided on the red flower as well. Our second case, Mrs. J, is a 68-year-old woman who came to us in April of 2025, and for 2 months prior to her diagnosis has experienced night sweats, fatigue, big loss of weight, 20 kilograms in 2 months, but most of all, very painful bullous skin lesions suspected of vasculitis. On physical examination, the bullous painful skin lesions were mainly on her upper and lower limbs. There was no organomegaly, no lymphadenopathy. She suffered from hypothyroidism, diabetes, and has had experienced acute kidney failure in the past. Her CBC showed slight leukocytosis with monocytosis, and her bone marrow aspirate and immunophenotyping confirmed the diagnosis of acute myeloid leukemia. Her karyotype was normal, and her molecular tests showed nucleophosmin mutation and FLT3 TKD mutation, which also put her in the favorable risk group according to the ELN guidelines. Her CT scan was unremarkable, her heart function was perfect, her lung function was perfect, but her comorbidity score was 2 because of her diabetes and also infection during the assessment. Also, her ECOG performance status was rapidly declining because at first she was at a 1, but during the diagnostic period, her skin lesions became so limiting of the movement that she became a 3. And this is the evolution of the skin lesions in just 1 week of the diagnostic period. During the time of the diagnostics, she suffered from septic shock, probably due to the skin lesions, and we were uncertain. Are the skin lesions the infection itself, or are they only a source of the bacteria? So we performed histopathology, a skin biopsy as well, which showed only inflammatory response. And luckily, our colleagues at dermatology told us to perform a dermatological antibody profile, which showed antibodies that can be often seen in paraneoplastic pemphigus. Due to the severity and the painful, limiting in movement nature of the skin lesions, we decided to start IV steroids together with starting the leukemia treatment. And we arrived on the second question. What would you do? Because it certainly wasn't an easy decision. Let's say A is blue again and B is red. Would you give an intensive chemotherapy regimen or think about venetoclax azacitidine because of the declining ECOG status? B is, let's do different. Let's A green and B yellow, maybe this time. Okay. We were a bit brave because during these steroids, IV steroids, the skin lesions became so much better to manage, and actually they disappeared in about a 2-week period, that we decided to give her a chance and started intensive induction chemotherapy regimen with midostaurin. Both of the patients received induction chemotherapy with midostaurin in the middle of May 2025. Since then, they've received 3 courses of consolidation therapy as well. They're now at the end of their 3rd consolidation therapy course. What I would like to draw your attention to, their treatment had basically no complications. An infection here and there, but typical good risk patients. What I would like you to draw your attention to are the response rates. Because after 2 treatment cycles, our first patient, Mr. K, was MRD positive in the flow cytometry, but completely MRD negative in the molecular testing. And on the other hand, Mrs. J, our second patient, was MRD negative in the flow cytometry, but MRD positive in the molecular tests. We're now awaiting impatiently for the final results of the MRD testing, but awaiting your response to the next question. Would you consider Mr. K, the first patient, a candidate for a transplant? Let's go with A, red, and B, blue. Interesting, about 50-50. And to be honest, I'm on the fence as well. What I've heard today from the train spotting lecture was that the molecular MRD after the second cycle is the most important prognostic factor. So maybe I will be brave enough, if this keeps up being negative, to let this patient be and just monitor the MRD with molecular testing, so as maybe not to give him another disease in a form of transplant. And question 3, what about the second patient, Mrs. J? Would you consider Mrs. J a candidate for transplantation? Let's go with A, red, and B, blue. Okay. Together with Mrs. J, we decided that she isn't a good candidate because she's really on the verge of frailty. She values her quality of life most of all, and she doesn't have a sufficient family support system to undergo such a procedure. But obviously, had she been a young, full of life woman, we would definitely consider her for transplantation. Thank you very much.
Thank you, Marta. And last but not least, Rafał Machowicz from Warsaw. Please, Rafał.
Thank you very much. Thank you very much for invitation to this great conference. I need to make a disclaimer before, because many people, when they heard that I will be presenting a clinical case, told me, no, I don't know anything about HLH, it will be so complex, I don't know, it will be like random answers. So maybe all of you know that I'm very involved in HLH, hemophagocytic syndrome, but this won't be about HLH. So a big surprise. Okay, and of course, it takes a village to raise a child, and of course, this patient was treated by many doctors who contributed to this success, and this is a picture of our department. So it was almost 2 years ago, end of September 2023, a 38-year-old woman was referred to emergency for neutropenia and thrombocytopenia. She was in good clinical condition, and she reported that for 1 year she had migrating joint pain. She had some rheumatologic workup, but it was 1 year ago. And then she was under orthopedic surgeon advice, but no disease was found. She had worsening pain in her joints. She lost 4 kilos. She had 1 day fever 1 week before and then recovered spontaneously. She had no toxic exposures, what was important in previous cases. And this is, yes, her artificial picture. It's maybe because maybe it will cover, it's not, we are not sharing patient data. Okay, and what were the results? So she had neutropenia and thrombocytopenia, which was slightly better than, it was 37 or 38 with which she was referred, and also with different anticoagulant it was equally same. And she had very mildly elevated CRP, no infection symptoms. Yes, what's important, lymphocytes are slightly elevated, and also monocytes are a bit elevated. So this is first day evening, or even night, and you're called to ER. And what would you do with this patient? Yes, so what's your... okay, so there is referred to outpatient and admit to the ward. Yes, the problem is that it's first day evening, so this is complex because she won't be accepted to outpatient the next day because we can somehow agree that probably she will survive overnight at home. She doesn't need really direct admission to the hospital to be saved. Yes, this is, but then there are organizational problems. Yes, because this is first day evening, then there is no doctor in outpatient department whom you can like arrange the visit with. Then there is weekend. You don't know what's the dynamic of this process because she has her CBC from this morning or yesterday. She made CBC and came with even slightly better platelets. So we don't know. And there are many what ifs. For example, if it was Monday morning, you just simply tell her, go there is outpatient. If it's Monday evening, you say, okay, come back on Tuesday. Yes, but here it's Thursday. So my idea was that, and there is also one more variable. Do you have any beds? Yes, and usually there are no beds. But fortunately, we found one bed on the corridor and invited her to this largest room that she can stay overnight, and we will make flow cytometry from peripheral blood, which will be taken because for bone marrow it will be complex because probably she would need bone marrow, yes, but just to make sure that it's nothing really important. So it was taken like 8 a.m. Then I left the hospital and I was starting my short, let's say, holidays. I went to Venice and I've got my personal map of Venice because I know at which point of this beautiful city residents call me about which patient. And I had to respond what's going on with those patients. So I remember this situation. But generally, yes, she was admitted, but maybe not for full diagnostic workup, but just to check her peripheral blood and to have her released on Friday and somehow arranged visit early next week in outpatient department, probably for bone marrow. It was the idea. But in this peripheral blood, there were blasts. And it was only 12%, only, meaning that, those lymphocytes that were a bit elevated, it was probably not this, monocytes were twice elevated, but so it wasn't very significant that was obvious that she had this leukemia, but she had. So she stayed in the hospital, and in bone marrow it was 88%, so it's no, it's not the missing part to 100%. There are different percents. It was BCR-ABL negative, and she had aberrant hypotetraploidal female karyotype. So this karyotype is very bad. So she had diagnosis of BALL, none otherwise specified. And maybe you spotted from the previous phenotype that she was CD20 negative. So she started with PALC ALL7. Our foreign guests probably know that we've got such organization, we've got such regimens for all the patients in our country. So she was below 55 years of age, so it was more intense treatment, but for adults. So it's a bit less intense than pediatric regimens. And intrathecal chemotherapy, she had no CNS involvement, she had leukocytosis below 30,000, so it was normal risk according to PALC, but high risk according to NCCN because she had this very bad karyotype. So this will come back. And luckily, she had CR MRD negative after induction, and it was sustained over treatment. She was all the time MRD negative, which is very good prognostic factor. But what was happening during the treatment? She had a lot of complications. Some of them are, let's say, planned, like severe myelosuppression. Tumor lysis syndrome, we didn't expect very big tumor mass, but it was. Febrile neutropenia, diabetes mellitus with steroids, of course, but then increase in neurotoxicity, which required dose reduction. L-asparaginase required dose reduction. This is also a bit problematic because it shows how big were the side effects and that the treatment is not optimal. And she had, of course, also sepsis and bacteremia, but the major complications were cardiac toxicity with chronic heart failure and subdural hematoma. So she missed her last lumbar puncture, and fortunately she didn't require any neurosurgery, and she had no CNS involvement, but it was quite a lot of complications. And now I've got a question about, and this hospitalization took 6 months because she couldn't be released between the cycles because there were complications and they were also delayed due to those complications. So she entered the hospital in end of September, and it was more than 6 months. Very end of March she was released. So what's your transplant approach? Yes, so I've got some reds, reevaluation, some definitely yes, but after some holidays, because it could be arranged that she could have her transplant in April, but she couldn't really bear it. So these are not, so green we know why, and no need for transplant, it would be too optimistic. Yes, we know this cytogenetics. And that the treatment wasn't ideal. Yes, so she was red, she was reevaluated after 2-3 months, but she wasn't just waiting, she got also maintenance therapy on in that time. And she tolerated very well. So she got a lot of chemo, including this maintenance, and had her allogeneic stem cell transplantation 1 year after diagnosis, without 1 day. And how do you think this transplant went? After, because I don't have any film clue here, so I've got a song, maybe by Carlos Santana. There's a song, Smooth. So the transplant went very smooth. The only complications were some mucositis, but she didn't require total parenteral nutrition, so it wasn't that bad, and some non-infectious diarrhea and heavy menstrual bleeding. Of course, they are complications, but they are very non-severe, let's say. So she had a transplant, and despite all those problems before, she had a very, very smooth transplant. Let's say hospitalization, and after transplant everything was fine, but after several months she had skin lesions. Unfortunately I don't have picture, but they weren't very spectacular. What's important, they included scalp, had atypical presentations, and there were multiple dermatology consults, leaning towards psoriasis or maybe atopic dermatitis. And there was periodic complete remission after IVIG because he had a hypoglobulinemia. So how would you classify such lesions? Psoriasis involves scalp, atopic dermatitis, in Polish AZTS doesn't. And also it can be GVHD or maybe allergic reaction. What's your approach? Okay, very nice. I see most of yellows, or almost all yellows, because this is interesting thing, because like dermatologists based on like skin biopsies had their theories, but the thing is that for me, let's say academically, she cannot have any autoimmune disease like psoriasis or Crohn or Graves. It will be all GVHD because she has a new immune system. So by definition, it's always GVHD, and it can be in the form of psoriasis. It can even benefit. She can even benefit from the psoriasis type treatment, but by definition, it will be always GVHD. So it was a bit tricky question, but with one correct answer. Okay, so we are reaching the end. So about the treatment of those lesions. So she had some topical treatment from dermatologists. She had still her immune suppression with tacrolimus, but maybe you've spotted that she had mixed chimerism. So in my mixed chimerism, you would like to taper immune suppression, whereas those skin changes were in the very, let's say, severe, but still it wasn't very pleasant for her. So you would like to taper immune suppression. On the other hand, you would like to elevate immune suppression. So maybe you have idea without test what could be the approach, what alternative method, not like oral medication, but some kind of procedure you could use? Yes, this is, we didn't discuss it before. So she had extracorporeal photopheresis, which also helped with dealing with this GVHD, and she has no skin symptoms. Thank you very much. And I know that I'm between you and the dinner, but I didn't know before. And very, very briefly, there's product placement or organization placement. There is Young EHA, which is a group in European Hematology Association, which helps young hematologists in their development. You can also apply to the committee and also check EHA website. You can be a junior memberships like 20 euros, so this is very cost effective. And you can also enter EHA campus with lots of very good educational materials. And as we have a proverb in Polish, cudze chwalicie, swego nie znacie. We've got also Young Hematologists Club, and I'm vice president there, and hopefully during the Congress of Polish Society of Hematology there will be elections for the new let's say committee members. So also you're invited to, and there is also interesting session during our Congress. Yes, so thank you very much. This is a park next to my hospital. Thank you very much.
Okay, thank you for staying till the end. And we've got 20 minutes because we've got the departure from the hotel by bus at 8 p.m. It will take like 10 minutes to get to the restaurant. Then if you would like to come back walking, it's 20 minutes. So see you at 8 downstairs in the reception hall. Okay?